इंटरजनरेशनल ट्रॉमा से गुजरे हम, बिकॉज वो हमने जेनेटिक्स में पास ऑन किया, तो वो सारी चीजों का इम्पैक्ट सोसाइटी पे आता है। तो हम जो करते हैं उसका नेक्स्ट जनरेशन पे इम्पैक्ट आता है, उसका नेक्स्ट जनरेशन पे इम्पैक्ट आता है। तो हम जो अब करेंगे उसका हम जनरेशन तक इम्पैक्ट ला सकते हैं जस्ट बाय रिकॉग्निशन। और ये जेनेटिक्स में कोडिंग होती है, जो हमारी चीजें हैं, जो हमारे एक्सपीरियंस है, वो फीडबैक, ब्रेन का फीडबैक जेनेटिक्स का फीडबैक नेक्स्ट जनरेशन, और इसी से एवोल्यूशन जो है वो चलता रहता है। इसका सबसे बड़ा एग्जांपल डॉक्टर यादव बताते हैं कि बिना मतलब एंटीबायोटिक मत दीजिए। तो बैक्टीरिया जो है वो सबसे तेजी से रेप्लिकेट करता है। मान लीजिए आपके पास 100 बैक्टीरिया है, आपने एंटीबायोटिक दिया तो 95 उसमें जो एंटीबायोटिक से सेंसिटिव है वो तो खत्म हो जाएंगे, मगर जो 5 बचे हैं वो एंटीबायोटिक से रेजिस्टेंट है। अब वो 500 बना लेंगे। अब उनको एंटीबायोटिक से काम नहीं होगा, फिर आपको और स्ट्रॉन्ग एंटीबायोटिक देनी पड़ेगी। तो वही चीज जेनेटिक्स में समझिए कि हालांकि हम लोग 70 साल 80 साल जी रहे हैं, बट जेनेटिक्स फिर भी हमारी वही प्रिमिटिव जेनेटिक्स है और म्यूटेशन होता रहता है। ओके, सो जो पहला साल है जिसको हम अर्ली इंटरवेंशन कहते हैं या जो चीजें कहते हैं, तो जिन बच्चों में फिजिकल डिसेबिलिटी हो जाती है, ब्रेन इंजरी हो जाती है, तो पहला साल सबसे इंपॉर्टेंट है, बिकॉज इसमें बच्चे का ब्रेन 10 सेंटीमीटर बढ़ता है। और जो डेवलपमेंटल ट्रॉमा पे एविडेंस आ रहे हैं वो कह रहे हैं कि प्रेगनेंसी बहुत इंपॉर्टेंट है, राइट फ्रॉम 4-5 मंथ्स ऑफ प्रेगनेंसी। तो वो अभिमन्यु की जो कहानी थी वो चीज सही है कि उसी समय से ब्रेन जो है वो शेप अप होने लगता है। तो एनवायरनमेंट का बहुत बड़ा रोल है। तो बहुत सारे लोग ये सोचते हैं कि वो विटामिन दे दे या विटामिन दे दे, अगर उसकी डेफिशिएंसी ही नहीं है तो उसकी जरूरत नहीं है। और हम लोगों में से बहुत सारे लोगों ने बायोकेमिस्ट्री पढ़ी है जिनको पता है कि नियोजेनेसिस हो जाती है, जो चीज नहीं है काफी सारी चीजें बन जाती हैं, एक अमीनो एसिड से दूसरा अमीनो एसिड बन जाता है। तो इंपॉर्टेंट बात ये नहीं कि हम उसको रिप्लेस करते रहे, जो चीज है उसको रिप्लेस करने से फायदा क्या, जो जहां पे दिक्कत है वो करना। सो न्यूरल माइग्रेशन इज वेरी इंपॉर्टेंट। तो जो मैं आपको बता रहा हूँ कनेक्शन, वो समझिए कि इस तरह से न्यूरॉन्स सरकते हुए जाते हैं, कनेक्शन बना लेते हैं और उसको मजबूत कर लेते हैं। ओके, सो यहाँ पे आप एक वीडियो देखेंगे, वीडियो नहीं चल रही है, तो यहाँ पे दिखा रहा है कि मान लो ये बच्चा जो है वो खेल रहा है। तो जब वो खेल रहा है तो उसकी आंखें उसके हाथ कोऑर्डिनेट कर रहे हैं और उसका जो कोऑर्डिनेशन पाथवे है वो स्ट्रांग हो रहा है। और जो भी बच्चा करता है वो रिपीटिशन में करता है, छोटा बच्चा रिपीटिशन में करता है, तो उसके पाथवेज ऑर्गेनाइज हो जाते हैं, फिर वो नेक्स्ट स्टेज करने लगता है, फिर वो नेक्स्ट स्टेज करने लगता है। तो एक पाथवे ऑर्गेनाइज होने में 2 महीने का समय लगता है। न्यूरल पाथवे ऑर्गेनाइज होने में 2 महीने का समय लगता है। तो अक्सर बच्चे जो हैं उनके माइलस्टोन आप देखेंगे 2-2, 3-3 महीने पे बदलते रहते हैं नेक्स्ट माइलस्टोन। तो बच्चा जो है वो बड़ा होता है, मैच्योर होता है। तो बहुत इंपॉर्टेंट है कि माइलस्टोन्स को जल्दी से अचीव नहीं करना, ये समझना बच्चा किस स्टेज पे है उसमें करना क्या है, नहीं तो न्यूरॉन्स पाथवे नहीं बनेंगे तो बाद में जल्दी से आगे जाके दिक्कत है। ओके, सो ब्रेन में डिफरेंट एरियाज मैप्ड हैं। ये आप देख रहे हैं कि ब्रेन जो है वो समझ लीजिए रेलवे लाइन की तरह है कि अलग अलग स्टेशन है और अगर वो आपस में जुड़े नहीं तो जिस एरिया से जुड़ेंगे नहीं वहां डिप्राइवेशन हो जाएगी, वो एरिया मैच्योर ही नहीं होगा और फिर बड़े होके डिसऑर्डर्स, डिसेबिलिटीज और ये सारी चीजें तो उसको आप करेक्ट नहीं कर पाएंगे। सो यूके में 2011 में वी स्टार्टेड यूजिंग अर्ली इयर्स फाउंडेशन स्टिल फ्रेमवर्क। तो दिस इज ये फ्रेमवर्क जो है इसका मतलब ये है कि इंस्टेड ऑफ लर्निंग हम फाउंडेशन स्किल की बात कर रहे हैं कि बच्चा लर्न तभी करेगा जब उसकी फाउंडेशन बनी हुई है। जैसे मान लीजिए हम इस होटल में बैठे कि अभी हर बच्चे को फोनिक्स करा रहे हैं. सो आई वाज रियली फैसिनेटेड कि किस बच्चे को पढ़ाना कैसे है वो कहीं लिखा नहीं हुआ था. एंड आई मेट मेनी एजुकेशन साइकोलॉजिस्ट. यूके में जाके आई यूज्ड टू सिट विद देम. बोले आप यहाँ पे क्या कर रहे हैं? मैं कहा नहीं, मेरे को तो सीखना है, तो आप मुझे बताओ, किताब बताओ. देन आई रेड ऑल द बुक्स. कहीं किताब में क्लियर था ही नहीं कि किस बच्चे में क्या करना है. स्ट्रेटजी सारी दी है, पूरी मैनुअल बुक सब कुछ है, मगर किसको क्या करना है वो नहीं दिया. सो इट वाज वेरी डिफिकल्ट. सो लिटरेसी भी है, समझो कि डिस्लेक्सिक लिटरेसी इज डिफरेंट, ऑटिस्टिक लिटरेसी इज डिफरेंट. जिन बच्चों में इंटेलेक्चुअल डिसेबिलिटी है यू विल यूज अ डिफरेंट टेक्निक. जिन बच्चों में न्यूरोटिपिकल डेवलपमेंट है यू विल यूज. 4 कैटेगरीज हैं, बड़ी सिंपल सी. उसको अगर आप स्कूल में अप्लाई कर लीजिए आपको लिटरेसी प्रॉब्लम नहीं होगी. और अगर आपने ये पांचों सही से नहीं किया है तो आपको मिलता है छठा, जो मैंने जोड़ा, बिहेवियर. Because most people are worried about attention span, behavior. But ये पांच leads to that. The family environment, family understanding leads to that. अभी जो आप बच्चे के साथ करते हो, आपके साथ कोई करे तो आपको भी behavior आ जाएगा. So very important section. So ये this is my kind of theory कि if there is a deficiency in number 2. So number 2 क्या है? Communication and language. Then you will have deficiency in all 3, 4, 5. So if you have an autistic child, you have problem with their communication and language, problem with their emotional, social and personal development, problem with their literacy, problem solving skills और behavior. ये सारे ही मिलते हैं. If you have, let's say if you have a child with deficiency in 3, so speech language communication की दिक्कत नहीं है. We have a case later today जिसमें मैं बताऊंगा. So only difficulty with their emotional development. Then also you will have problems with their problem solving, literacy and behavior. तो ये ऐसे ही है. तो नंबर 5 है ADHD. तो अगर सिर्फ 5 में डेफिशिएंसी है तभी ADHD डायग्नोस होना चाहिए. बट अगर 2, 3, 4 में है तो 5 तो मिलेगा ही मिलेगा. बट आप ट्रीट 2, 3, 4 को करोगे. अगर आप सीधे 5 को करोगे तो आप जैसे पैचअप वर्क करते हो. इसीलिए इन बच्चों में प्रॉपर आउटकम ही नहीं आता. ठीक है. तो मोस्ट चिल्ड्रन हु आर न्यूरो डाइवर्स, विजुअल पाथवे पहले बनी थी, ऑडिटरी पाथवे उसके बाद बनी है एवोल्यूशन में. तो अगर आप एवोल्यूशनरी मॉडल में जाते हैं तो यू विल सी दैट दे हैव अ गुड विजुअल मेमोरी. They are physically well and strong, and they thrive on good structure and routine. Sometimes they will catch on कि आपने तो पहले ऐसा किया था, अभी आप ऐसा बोल रहे हो. तो important है कि you have a good structure and routine at home. Otherwise, if the parents don't have a good structure and routine, they're doing anything, they're talking anything, then the child will have lots of problems. They will no. Yeah, so that brings my next question कि ये अच्छा वो दूसरे that is a different presentation. I'm sorry. Yeah, so to join the course or if you want to know more about the course, it's only 4-hour course. You can scan it and share with all the school teachers that you know, all the school SANCOs that you know. It's a very comprehensive course. It's got all the resources. So जो भी हैं, please आप इसको scan कर सकते हैं. ठीक है. थैंक यू सो मच. आपने स्कैन कर लिया होगा. सो नेक्स्ट इज हाउ टू डू असेसमेंट एट स्कूल. शैल आई डू दैट और शैल वी आस्क द स्कूल टू प्रेजेंट, बिकॉज मोर रेलेवेंट इज हाउ टू डू असेसमेंट ना. ओके. So I know you are there for the school presentation, but I want to talk little bit about how the school should assess children. Then I'll give you the prize. Okay. Right. So after lunch. Let's see. Is it hard to hear? Hard to hear? Yeah. Okay. Okay, we'll sort out the sound and then we'll do it. Thank you. Thank you so much. So Next, what I will do is I'll just talk about this very important topic of how the school should do assessments. Very small topic. I shouldn't be doing this, but I'm doing it. Right. So this is very short presentation. We'll finish in 10-15 minutes, and then we can go to the other presentation. So please, may I ask you to get on to new mentee. This is an interactive session, so please do it. This will be nice to do it together. Okay. So, anyone from school here? Anyone who has worked at school and who? So very important. I need some answers. Or any psychologist, all the psychologists who have friends working at school. So please take this. Everyone got the mentee.com? हाँ अब आ रही इसके बाद करता हूँ. Okay, shall I start? Yeah. So the first question is, what are the roles of school counselor? What are the roles of school counselor? Because there are so many children, all the burdens fall on them. So they are like superheroes. But what is their real role according to you? So let's say your children are going to school. What should you expect from the school counselor? Zero responses, please type on the mentee. While we are getting this, responsibility for counselor is to provide counseling support, maybe provide academic guidance, individual education plans. Maybe if there's a crisis and some child is going through a big crisis, then going through mental health support and provide strength-based approach. So I think all of the counselors are trained in doing that, but I'm sure without training of all the teachers and without right support from parents, the job is very, very hard. I will not like to do that job. Okay. So in UK, we have a similar post and they are called SENCOs. So they are called Special Education Needs Coordinator. So they are teachers. So let's say some teacher has worked for 10 years, they are very good. So instead of hiring the psychologist, no disrespect, they train that teacher in this SENCO course, and they find that they are able to make sure that they are able to work better and with most teachers. So that is, I think, an evolution that has happened, and somewhere that's something, that's an approach that we can take. So all teachers to be trained, and then one of the senior teachers to be trained in doing the counselor role. And yes, you can have psychologists coming from outside. You don't need to hire them. You can have specialist people coming from outside if you need. So that's what they do in UK. Yeah, it's not a perfect system, but that's what it is. So in UK, they are again responsible for identification and assessment. So let's say a child is struggling, so they will make sure that they have got some tools. They can do the initial screening, they can speak with all the teachers, collect the data, and they will know, okay, which team to refer. So they are trained into that much only. So all children, before you do the intervention, we try and say which pathway to follow. So pathways are set for them. So usually most teachers are, if they're given a flow chart to say, child is doing this, not doing this is the path. Very simple. So we in my course have done that. And that without diagnosis, if you're just developing education healthcare plan, it's like again shot in the dark. अंधेरे में तीर लगा तो ठीक नहीं तो कोई बात नहीं. So it's very hard. Diagnosis tells you what to do, what to expect. Monitoring and review, again you need to know that what are the outcome measures, and then only you can monitor and review. And constant training should carry on. So schools should get constant training. Every year they should get कि क्या क्या cases उनके रहे, क्या experience रहा, and based on that more tailored training and support should be there, and that will let the school grow, and the school can be the best school to promote very good physical and mental health in these children. So this is case which I recently saw, just coming, I think last week we saw 16-year-old girl, and they came to my private clinic in London, and the parents were really worried. Usually, sometimes they come because they don't know where to go, so they come to neurology clinic with psychological problems. So anyway, so this girl was very, very anxious, and parents were thinking that she has ADD. So they thought that the child has attention deficit disorder. So she will go to bath, she'll forget to come out, always late for school, doesn't like to mix with a lot of people, very anxious, was very good in studies until 12. Now she is showing a lot of academic struggles, socially withdrawn. So yeah, so when this is more like a regression, so sometimes they come to say, okay, is it a neurological regression, or what has happened, what tests we need to do and stuff. So this is a very long history. We have changed the name. So Ella exhibited frequent emotional outbursts and intense mood swings, often becoming overwhelmed by seemingly routine situations. Her parents recognized high level of anxiety characterized by excessive worry about her academic performance, which significantly affected her day-to-day functioning. So when you have a girl with autism, they will be fully functional. They'll talk early. This girl started talking at 10 months. So usually they can show a lot of fixation to outcome, and that's how they develop a lot of overthinking behavior. So this child, the main problem was anxiety. So my question was, is it anxiety on its own or anxiety because of autism? Autism related anxiety in a girl. So academic struggles, usually she was fine, but she has declined. So again, we want to look whether there is some neurological thing causing a decline in her cognitive functioning, memory and stuff like that. But trauma attachment can also do it, so it was very challenging. Social withdrawal, why would a person who is very functioning show a social withdrawal? So again, we wanted to say, okay, why is she looking for loneliness, isolation? And she was in tears. While she was talking, she was crying. So one thing we identified, okay, it's not a neurological problem, it's more like a psychological problem. So the question was, is it autism related anxiety or is it anxiety on its own? So we did the test, and we used camouflaging test for older children in autism, and it was very positive. So she said that just to stay in a social situation, she has to hold herself, she has to think, she has to plan, a lot of difficulties. But once she knew about autism, and once she knew that she is going into a repetitive pathway, she is overthinking, it became so easy. She went out smiling. You know, now I know that why I am like that. So I met a girl recently, she is 29 years of age, and she got into IT and she got into PTM. She was doing a job there, and some bullying happened and she left the job. And then after that she had a lot of difficulty. She doesn't want to do anything. but she was topper all throughout. So sometimes autism can present in a very high functioning people, IAS, doctors, engineers, where they are really, really fixated on their job. Everything else doesn't matter. And sometimes that causes impairment in their life when they find failure. So it's very simple. When you just tell them that's how your brain is working, they start to respond. So what would teacher do in this case? In this last case where the child doesn't want to go to school, is having lots of emotional outbursts, what would the teacher do? Yeah, I think teacher should just identify and refer. So mainly very important is that it's like the teachers are like there to identify, to say, okay, something is not right with this child here. Not to ignore कि अरे पढ़ने में तो अच्छी है, स्कूल में कोई प्रॉब्लम नहीं है. And in London, the teacher said there's no problem. The child is fine. Yes, she doesn't want to come to school. Yes, she cries sometimes. Yes, she gets angry. Yes, she is avoiding. Yes, she doesn't look at people. That's okay, but she is good in studies. So that's the approach sometimes people take, and that's why, because there's so much waiting list to see someone in the NHS. So people then go private and see. Yeah. Okay, so what do you think is going on here? So next question is, what do you think? I already told the answer. So So autism in girls can present like that. So always remember that autism is nothing to do with speech. It is to do with their strong interest, strong attention. So early on, if you tell someone that you have to come first, and they come second, they break down. So very important that in very, very high performing people, autism can break them down. They will have sleep difficulties, they will have lot of anxieties, lot of adjustment behavior. So she sits in her room and then she tiptoe walk to calm herself down. She sits in her room and rocks. That calms her down. So lots of adjustive behavior, which the parents said, oh, you do that? I don't know, I've never seen that. So it's very important for these children to get referred and get the help. Okay. So what, I don't know, this is the question I want to know. So if you have a child like this in your school, what resources you are using? Anyone? If you have a child like this at school, you can type on Menti. Do you have any resources like I can read this or I can give something to parents? Or would you like some resources? So let's say you have a child you think need help. How would you help them? That the child is not doing it deliberately. It's not that the child doesn't want to read, doesn't want to go to school, doesn't want to talk. It's like if you push them, like suppose the trauma theory, the lion is sitting there, you push them to say hello to lion. So next time they'll not say hello to anyone. So they might have been through regular trauma because they are not doing, they are avoiding. So is there any resource? Would you like me to provide you a resource? Because this is YouTube live, so I will talk about a resource. Yeah, so in this child what we did was, we did the assessment and profiling and everything. So assessment is not just the child but their family dynamics, the child's foundation skills and their different behavior, putting them into categories. So we call it as brain early skill test, the BEST test. Not because it's best, it's an abbreviation, BEST early skill test. Okay, so functionality has to do with, so we found a deficit in functionality, emotional regulation, parental stress index, and diagnosis specific behavior. This is how our digital thing is. Any school can use it. So if the school want a platform where they can identify children and monitor them, they have all the data. I made a very simple system, just put the data will give you a resolution for class, resolution for parents, and that's how it looks. So in this is the graph. the left graph if their functioning skill, how much they are functioning. So you see a child is fully functional, but you see the child is not reciprocating as much, is showing a lot of restricted and repetitive behavior. So those pathways have developed. So we just change the environment to help the child, and the parental stress is very high because they are thinking, why is my child doing this? Is all unnecessary things. So what they think is this is unnecessary. So instead of addressing it, they want to get rid of it very quickly, which increase the problem for the child. So when we do an assessment, they get targeted videos on their phone. So they will know exactly what to do. There is no need to come to any therapy center, nothing, no intervention. I know there are lots of centers in Gomti Nagar, but now we have a way by which children don't need to come for any therapy. They can do it at home. Any physical, any speech language communication, any educational, anything. Everything can be done through parents. So we call it as parents-led program. Okay. So for long-term changes, we need to improve resilience, improve academic and social areas, improve relationship with parents. And if you want a resource, one resource to provide to your parents to say, okay, child has got autism, I don't have the time to explain, just ask them to scan this. They will have all the information they need in Hindi. So autism, epilepsy, cerebral palsy, any genetic problem, Down syndrome. Also there is a plan of how to improve the daily life. Like they say how to get the toilet training, how to get better eating, how to get a better relationship with food. All of that information is available for free. They can just download the app and they can get all that information. So it's there. So if anybody want to take a photo, share it. So this app is available on App Store as well as Google Play. Okay. So the time now is 12. Okay, so we just go on the link. So we have one speaker from UK. So it's 6:30 there. So he'll join at 7. In the meantime, I will continue and talk about neurological examination. It is relevant for everyone because my presentation I target at parents. So if parents can understand, the teachers will understand, then the doctors will understand, and psychologists will understand. But this is relevant because we are working in a team. So if only the doctor can do or if only the psychologist can do, then we have a problem. So this is all a teamwork. Okay. And in the afternoon, we'll cover a lot of these scenarios practically. So you will have real people talking to you, and we have made them real good actors. So they'll be crying and they'll be asking you questions, and we'll teach you how to talk to them. So it's a lot of communication scenarios in the afternoon. But they're not parents, they're just actors. So school presentation is there, but they want to do in the afternoon. So we'll finish all of this and okay, so this is my last presentation. So I will ask you to scan the code, please, again. So I hope you are finding it useful. Yes? Okay. Ready? Everyone has done it? हो गया? Menti वाला हो गया? Okay. Okay, so this is approach to child neurology. So often this is the big problem, that it is not clear whether the child has a developmental impairment or a neurodiversity. And how do we give different strategies? So in this one talk, I'll tell you every single thing. If anybody can understand this talk, You don't need me anymore. That's it. Done. So, this is, I've got 3 cases to start with. So if you read it and then the mentee will ask you questions. Dr. Neeraj, have you downloaded Menti? Okay. No, it's on your phone, Just scan the, doctor. Sorry. आर्या, इनके पास कोई घड़ी होगी क्या? हाँ, वॉच. अगर क्लॉक हो तो उसमें टाइम दिखाएगी. Okay, we are starting now. It's done. Okay, so this child, so she is thinking, okay, my child has dyslexia, I am trying to help with the studies, he is getting angry, I am giving him a timeout, and timeout is not working. So, how do I help my child? Because if you read any parenting book, they will say, okay, give timeout. But in a neurodiverse child, the typical parenting doesn't work. So that's the whole, if there is one message you want to take, this is one message. That typical parenting skills will not work with neurodiverse child. Okay. So what alternative approach might be more effective than timeout in a dyslexic child? Because we are going to talk about strategies, so I've started from questions. I've got 3 scenarios. One is a neurodiverse scenario, one is a genetic scenario, one is something else. So please answer. Only 7 responses. Okay, yeah. Very good. So, the right answer is the blue one, and you will not completely ignore the child, and you will not give additional tasks because that will. Okay, so you provide small task and lot of praise, and then you will see that things will be better. Okay. So, this is a 6-year-old who attend physiotherapy clinic for spastic diplegia. So he was diagnosed of spastic diplegia, which is a form of cerebral palsy involving the lower leg. Diplegia means involves the lower leg. And in this, they have difficulty in walking. So the parents have been doing therapy for months and they are seeing some small improvement कि हाँ कुछ तो है फायदा, थोड़ा सा तो अच्छे से चल रहा है and all that. The child also enjoys sessions कि ठीक है चलो balancing game है ये सब है, we are doing it. Suddenly he has a deterioration in walking, so he can't walk, which is more than usual because there should be no deterioration. Now he started to get tired quickly, and it seems that instead of improving he is going down. And during a simple walking exercise, one day his legs give out and he falls. So this is unusual that this child does this in cerebral palsy. It can happen, but it's unusual. So the doctor said, okay, let's do some additional test, and found that the child has actually a muscular dystrophy. So muscular dystrophy means that the muscles will break over a period of time. So sometimes if you make a diagnosis which is not right, and if you give therapy for that diagnosis, but the diagnosis is something else, then you can actually cause more harm to the child than benefit. So in this case, we saw that although the child was diagnosed of spastic diplegia, but his difficulties were because he has muscular dystrophy. So if he has muscular dystrophy over a period of time, we would see deterioration, but rigorous exercise will mean fast deterioration, very fast deterioration. So very important to recognize and provide the right intervention. So that is the whole aim that we are doing this workshop. So in the first one also, dyslexic child, timeout doesn't work. Second one, spastic child, careful what exercise you are giving, because not every diagnosis has one exercise. Very important. Oh yeah, it's a simple one. If you want, you can write it, or I'll move on. I've already given the answers, I'll move on. So, next case is a child with autism. This one I'll not give the answer. Is a child with autism who frequently walks on tiptoes and experience motor tics. So tics are often confused as epilepsy. They come to my epilepsy clinic कि ऐसे मुँह कर लेता है, हाथ ऐसे कर लेता है, ये कर लेता है. So tics are just an adjustment of the child. So some children who feel that they are not in sync with the environment, they have overload, and then they have motor movement that calms them down. So sometimes children will do motor movement to calm them down, which is not a problem, but it is actually their adjustment. Unfortunately, he was treated for epilepsy. And because he was walking on the tiptoe, he was also diagnosed cerebral palsy. I don't know where, but so sometimes children will show motor function. In autism, most of the motor function are their adjustment behavior, where they will do things which are mimicking other medical diagnosis. Very careful, very important for the doctor to look at the whole child, look at what the child is doing, and not to make incorrect diagnosis. In this case, unfortunately, that didn't happen. The child had unique autism-related behavior, including all of these, but was treated with medicine to reduce the tone in the leg. So if you have a child with autism who is walking on the tiptoe and you give medicine to reduce the tone of the body, his whole body will go floppy. They'll go sleepy, they'll go floppy, they'll go loose, they will develop lots of medical complications, constipation and stuff, and their whole thing will go down. Very important to choose the medicine properly. Anyway, so it's yeah, so second paragraph is just talking about that. Yeah, and then had some additional behavior. So yeah, so the question, okay, so there was a question here which is not coming, but the question was, why was the child walking on tiptoe in autism? Or why would children with autism walk on their tiptoe? Anyone? Why would children with autism walk on their tiptoes? All of them are right, but the real answer is that when you stretch your muscle, जैसे आप योगा करते हैं ना, तो आप बॉडी को स्ट्रेच करते हैं, तो ऑटिज्म के बच्चे नेचुरली योगा कर रहे हैं. जैसे ना ओम जैसा बोले ओम, तो भी यू सी लॉट ऑफ पीपल विद ऑटिज्म, दे आर जस्ट ब्रीथिंग आउट. So lot of the things that they are doing, they are actually calming themselves down. Yeah. So very important not to take that away, because if you take that away, then their shield is gone and you will have a major problem. So most parents come with you to say, बस एक problem है, that is tip to working, and if that is sorted, done. So they have a different, they're in a different planet altogether. So very important to understand that what is the child's problem. So, but I see a lot of parents like that. They are going for heavy shoes. So the child is given cerebral palsy, heavy shoes, and the child is not able to walk, then they start falling. So I've seen it all, but I don't want any of the children to suffer like that. Okay, so how do we approach child neurology? So I think very important to look at the bigger picture. So when we say history, like today I told you the whole evolution from 2 lakh years old. History is that old for human history. So same is neurological history. Starts from there, pregnancy, and before that other children, before that family members. Everything is important. Every single detail might be relevant. So neurology is like a painting, where you first put in everything and then you paint it. You don't conclude early. The reason I love neurology is because it is difficult. And it is difficult because you have to put everything together. You can't just do a blood test and say it's anemia. You can't say this is cough, take the cough syrup. That's not how it is. It is challenging. So history is very important. So my next question is for everyone. Tell us what important history would be in child neurology. For you. So when you're taking a history, what is most important? कि इसको तो छोड़ना ही नहीं है. We'll take more. I must say there is no right or wrong answer. There is no choices. I just want you to think. I always say one thing to parents. I have some very, very big doctors whose children have autism. So I say to them, free yourself from perfection. Do the imperfect thing. Do the wrong thing. Doesn't matter. Just do it. So, yeah, lot of developmental history. Very good. Okay, so more history. So again saying more history. So here, I've given you options. So presenting complaint, more important. Family history, more important. Medication history, more important. Or developmental history, more important. I'll tell you how I use it. I just want to ask, is English right? My English is okay, or shall I speak in Hindi? Everybody is able to understand my English? Yes. This is very important. I'll tell you how I use it. Yes. हाँ, ठीक है, मैं समझ रहा था. ये बहुत मजेदार होने वाला है ये स्लाइड. ठीक है, तो इसको मैं ऐसे यूज करता हूँ कि पेशेंट अगर मेरे पास आया और मुझे दिख रहा है कि हाँ बच्चे में ऑटिज्म है और पेरेंट्स कह रहे हैं कि बस बोलने की समस्या है, आप इसको कर दीजिए. तो प्रेजेंटिंग कंप्लेन से समझ में ये आता है कि पेरेंट्स बच्चे की प्रॉब्लम कितना समझ रहे हैं और उनको कितनी हेल्प की ज़रूरत है, एडिशनल हेल्प की ज़रूरत है. तो जब हम किसी पेशेंट से बात करते हैं तो ओपन रहता है कि भाई क्या प्रॉब्लम है बताइए. हमें तो पता है क्या प्रॉब्लम आपके लिए क्या प्रॉब्लम है बताइए. तब हम समझते हैं कि जैसे मैंने 2 दिन पहले एक बच्चा आया था कानपुर से, तो उसको बेचारे को 2 या 3 दवाई चल रही थी सीजर की, बट बेसिकली उसकी जो डायग्नोसिस उसमें कोई सीजर की दवाई की ज़रूरत नहीं थी या एक मेडिसिन से काम हो जाता. बट दे वर सो वरीड कि बस सीजर ना आए, सीजर ना आए. तो मैंने बोला कि देखिए 2-3 दवाई देंगे तो वैसे भी आपको नुकसान होने वाला है. सो वेरी इंपॉर्टेंट, प्रेजेंटिंग कंप्लेन इज वेरी इंपॉर्टेंट बिकॉज दैट टेल्स यू कि पेरेंट्स क्या सोच रहे हैं. एंड मे बी दे आर थिंकिंग इन ए वे बिकॉज दे आर फ्री, दे विल गो टू सम अदर डॉक्टर, दे विल गिव मोर मेडिसिन, बट वो बच्चा खराब हो जाएगा. सो प्रेजेंटिंग कंप्लेन जब आप डायरेक्टली बाद में एड्रेस करते हो कि आई नो यू आर थिंकिंग दिस, मुझे पता है कि आप ये सोच रहे हो, बट बच्चे की नीड ये है. सो प्रेजेंटिंग कंप्लेन फॉर मी इज वेरी इंपॉर्टेंट. फैमिली हिस्ट्री इज ऑफन मिस्ड बिकॉज द अवेयरनेस ऑफ ऑल दीज थिंग्स हैव जस्ट कम. तो हमारी फैमिली में भी ऐसे लोग हो सकते हैं जिनकी पर्सनैलिटी न्यूरो डाइवर्स पर्सनैलिटी हो सकती है या वट एवर, वी डोंट नो. So yeah, so I think it's okay. अगर फैमिली हिस्ट्री बहुत प्रोमिनेंट कुछ है तो लोग बताते भी नहीं है कि हमारी फैमिली में ऐसी कोई प्रॉब्लम थी. So I don't find family history very useful. मेडिकेशन हिस्ट्री इसलिए इम्पॉर्टेंट है कि अगर डेवलपिंग ब्रेन पे, ब्रेन जो है वो कनेक्शंस बना रहा है, ब्रेन को सिर्फ एनवायरनमेंट चाहिए, उसको न्यूट्रिशन डेफिशिएंसी अगर होगी तो चेक करके देनी है. बट डेवलपिंग ब्रेन पे अगर ऐसी दवाइयां चल रही हैं जो ब्रेन को स्लो कर सकती हैं, तो उसका लॉन्ग टर्म जो प्रॉब्लम है वो बहुत जबरदस्त है. जैसे मैं एग्जांपल देता हूँ सोडियम वैल्प्रोएट का. तो अभी सोडियम वैल्प्रोएट अगर हम यूके में प्रिस्क्राइब करते हैं तो हमें 2 न्यूरोलॉजिस्ट को बैठ के उसको करना पड़ता है कि वी आर श्योर कि दिस इज द ओनली मेडिसिन, ओनली ऑप्शन. इतना उन्होंने वो किया हुआ है साइड इफेक्ट प्रोफाइल की वजह से. और ऑलमोस्ट बैंड है कि 1 पर्सन कांट प्रिस्क्राइब इट. यू नीड 2 पीपल ऑथेंटिकेशन टू प्रिस्क्राइब सोडियम वैल्प्रोएट. हमारे यहाँ पे थोड़ा जल्दी यूज हो जाता है. सो मेडिकेशन हिस्ट्री इज इंपॉर्टेंट. एंड डेवलपमेंटल हिस्ट्री का मतलब क्या है? एक्चुअली यहाँ भी नाम की समस्या है. इसका नाम होना चाहिए था ब्रेन डेवलपमेंट हिस्ट्री, बट यहाँ पे इन्होंने बोल दिया डेवलपमेंट हिस्ट्री, तो बच्चे का डेवलपमेंट. और इसको लोग टारगेट भी मान लेते हैं कि बच्चा कब बोला, कब ये, मगर ये बेसिकली बताता है कि ब्रेन डेवलप कैसे हुआ, उसकी हिस्ट्री कैसे हुई. और एक और कॉन्सेप्ट जो मैं यूज करता हूँ वो है डेविएशन. कि जैसे मान लो कि आप जा रहे हो लखनऊ से आगरा, अब डेविएट होके वाराणसी से होके गए, तो जहाँ पे लगना था शायद 6 घंटा, वहाँ पे लगा 16 घंटा. सो डेविएशन अगर हो रहा है ब्रेन के डेवलपमेंट में तो वो समझना बहुत ज़रूरी है. ओके, सो अगर आप इफ़ यू टेकिंग अ हिस्ट्री और आपको पेरेंट्स को याद नहीं है कि वो कब हुआ था, तो आजकल बहुत अच्छा है कि फ़ोन में फ़ोटो देख लीजिए कि अच्छा फर्स्ट बर्थडे की वीडियो दिखाइए, वो तो सबके पास होती है. सेकंड बर्थडे की वीडियो दिखाइए, थर्ड बर्थडे की वीडियो दिखाइए, सब पता चल जाता है. बिकॉज यू कैन सी कि बच्चा क्या कर रहा है, घर में क्या हो रहा है एंड ऑल दैट. तो थोड़ा सा टाइम लेके यू नीड टू लुक कि ब्रेन डेवलपमेंट कैसे हुआ था. तो डेवलपमेंटल हिस्ट्री में वीडियोज आर वेरी इंपॉर्टेंट, उतना टाइम देना पड़ता है. माइलस्टोन्स आर देयर जस्ट टू टेल अस कि भाई वो ब्रेन डेवलपमेंट सही प्रोसेस में हुआ है कि नहीं, गैप्स तो नहीं छूटे. एंड डिस्पाइट नॉर्मल माइलस्टोन न्यूरोडाइवर्स बच्चे मास्किंग करके निकल जाते हैं. सो यू हैव टू अंडरस्टैंड दैट नॉट ऑलवेज कि हर डेवलपमेंट नॉर्मल है, पढ़ाई नॉर्मल है. अभी जो मैंने पिछले एग्जांपल दिया, इवन देन यू कैन मिस इट. बिकॉज जैसे ऑटिज्म अगर है और उनकी स्ट्रॉन्ग इंटरेस्ट पढ़ाई है या बोलना है, सो दे विल बी हाइपरलेक्सिक. 10 महीने पे बोल रहे हैं, क्या जबरदस्त बोल रहे हैं, सबको सब कुछ बता दे रहे हैं, नॉलेज बहुत अच्छी है, बट दे स्टिल हैव डिफिकल्टीज जो वो अकेले फील करते हैं. ओके, सो डेवलपमेंटल डेविएशन का मतलब क्या होता है, जैसे मैं आपको दिखाता हूँ, अगर ये वीडियो चल जाए तो ये मेरे पेशेंट हैं लंदन के. साउंड आ रही? जो लोग मुझे जानते हैं दे विल नो दे मेरे ही पेशेंट हो सकते हैं ऐसे. Okay, so what was happening in that video apart from the nice song? So let me tell you. So this child is looking at the monitor, listening to a song, and the child is strongly focused on it, not even looking at the father. So when children have autism, they have strong interest in what they are doing, strong interest, and they ignore their surroundings. And later on, they might develop adjustment where they need time to do something in repetition. That is their adjustment. इसी को डिस्टर्ब करने के लिए father is also sitting and he is singing the same song. So very important that we need to make sure that they don't have prolonged time where they are repeating, because when they are repeating, then their brain will go into the loop. That will become the problem later on. So we say disturb them. So what we see here, you see, he doesn't look at the father, but the father is not worried. He's sitting next, listening to the same song. It's very annoying and disturbing, but that diffuse their intense focus. Because later on, obsession is nothing but this intense interest. Okay, so for the next video, please camera of audience की तरफ कर लीजिए. Please camera audience, no recording because I'm audience की तरफ, because this is my patient. I don't want to disclose their identity. तो YouTube live में कैमरा उस पर कर लीजिए, please. Okay. For the next 2-3 patients, we will not take videos. Okay? Sound is coming? Ranvijay? Sound.
It wasn't now. You have to keep. You can do these if you want to. If you don't, stop.
Okay.
Do you want to do these?
Mhm.
Up there?
Up there?
I'm pretending this. No. Yes. A little bit, but you have to just put them down like that. Just do that. With
Which one to pick up now?
You can pick one yellow one. You can pick one pink one. Which one do you want?
Both.
Oh, okay.
Yeah?
Good job, Mommy. The scales on top of the bed. It has this bed. This is the bed, Mommy. It's there. It's a bit small bed, though, but but you can see it.
Okay. Lovely.
Yeah. Now, you have to do that. So when they're sleeping, it's
So what you see here is the child is in his own agenda, trying to teach the mother. This is when he is happiest. So most children with autism, they want to be the teacher. That's what it is. They want to be the leader, the teacher, the ruler, the person who knows everything. And when they find that space, they're happy. That's when you can bring them out of their own agenda. The mistake we are doing is we start teaching them when they are in their own agenda. And that gets them more intense in their interest. So this family has recently joined my program in London. And we don't do any therapies or anything like that. They just have the videos, they know what to do, and they are just supported by talking, and we have really good results. So children with autism don't need any therapy. Parents need to know, what should I do? How do I respond to my child? How do I show response? So what you see here is just mother knows exactly what the child will do because the child has autism, and the mother knows that, okay, how do I respond to his extreme.
Okay, I think it's finished. Did you finish?
now, and just
Okay.
Before they joined the program, there was a lot of shouting, lot of aggression, lot of hitting, because the child can talk, was saying a lot of inappropriate things to the mother, and she was crying. She had a very bad time.
we have to go all through it.
Okay, bye.
Do it. And just a bit. My phone.
So are you able to see strong interest, own agenda communication in this child? So that's what it is. Autism is all about own agenda, strong interest.
Everything felt in this.
Okay, you come here now.
Just joking, Mommy.
And when the mother listens to the child, then the child listens to the mother. So the to and fro communication start very easy. It's like coconut, hard outside, so very responsive parenting. But it was very difficult. I was holding my head. Mother didn't listen. She was talking so much, and it was very hard. So yeah, I've told you the answer, what you see in this video. So now I'll show you something else. So sometimes children can have developmental delay and association together. So some children will not go to mainstream school because they have significant development delay, plus they have deviation, strong personality and stuff like that. Let's show you this. No video, no video, no video. Video नहीं करेगा. So this is the child, you see. Can you see the child is having difficulty even getting from the sofa? So sometimes you can have physical difficulty as well as speech language communication and everything else. Everything is delayed, what I told you. So the intervention in them is different, and the intervention in children with just neurodiversity is different. That is the whole key. And if the parents know what to expect, what to do, then it's very easy. Okay, so now you can up mode. So when I examine a child, just because I don't want to forget anything, I start from the head. So very important neurological examination is how big is the head. So I think yesterday or 2 days back we had a child with epilepsy and it was not matching up. Epilepsy, autism, and things were not matching up. So we did a genetic test and it came out as positive for frontal lobe epilepsy, but it also showed a large head. So we measured the parent's head and the child's head, and the child's head was as big as the father. So macrocephaly. So that gives me the diagnosis to say, okay, we need to look at holistically. A genetic diagnosis was there, but that will tell me what medicine to use, how long the seizures will be, why there is a problem. So head circumference is the first thing you see. Eyes is the doorway to the brain. So if a child has got visual impairment or a squint, then they will have difficulty making the right image, then they will have coordination difficulties, fine motor difficulties. So very important that all children who comes for development delay, you have a system to check their vision, you have a system to check their hearing. The next thing is feeding and diet. Very important. If they don't have right nutrition, obviously they will, but that doesn't mean you use supplements. Look at their height, weight, use normal centile. Very important, very easy. And then talk about normal food. There is no better food than Indian food. But also because we use such a good balanced diet, there is no need for supplements if we have a good healthy 5 meals a day routine. So 3 main meal and 2 snacks. That's what we need for children. So they develop a healthy relationship. So children learn by what their parents do. So if you are eating together, if you have a place where you eat, don't eat where you play, don't eat where you sleep. Have a separate place for eating and use that for eating only. And then everybody has come and you have a time, you eat, and then if the child is wanting, doesn't want to eat, that's it, time done, and then repeat. Time done, repeat. What happens is we see parents forcing the food and hi mera beta kha lo and all that. So that doesn't work, because in the long run we want them to have a healthy relationship. Sometimes that causes phobia, because even food causes phobia. So if you're putting things in the mouth and they don't want it, again the trauma theory is not autism, you're causing trauma to your child and your child will have phobia. So feeding, very important. So early on all babies feed milk. If you are able to swallow milk, then you have a normal swallowing. Because if there is a swallowing problem, liquid will be the problem, not the solid. So if they can't swallow liquid, so usually early on feeding problems, if they have brain injuries and stuff, they are not able to take milk, they're taking longer, their weight is less. Identify them, refer them for peg feeding supplements. Very important, then they get early nutrition. And then later on, all this autism feeding problems are mainly because parents are forcing children, and that's why children are getting traumatized. And then there's a new term now, EFRIT, talking about food and stuff. And then talk to your child. As soon as your child comes in, look what they're doing. Are they looking at you? Are they smiling at you? Are they looking connected to their environment? If not, later on there'll be a gap. So what we need to do is very basic things. At schools, look at your children. Are they interested in other children? Are they playing appropriately? If not, then maybe there is something that needs further evaluation. Okay, so sometimes when I see children, usually I'm able to find a cause just by looking at them. So this is called gait examination. Once again, camera touch. Okay, so this is question answer actually. What is the time? 12:30? Okay, let me know when he joins. He's joined. Okay. तो इसको चला दो ना. Yeah. Hello boss. Yeah, his name is Vas. So 10 more minutes. Yeah, 10 more minutes. I'll connect you. On the phone. So what do you see here? Mother is calling the name, the child is not listening. Usually you will see a heel-toe walk. By this age, children start walking with their heel-toe. Heel-toe. She is walking on the tip-toe heel. So that's very important. Look at the gait, and she has to move her arm a little bit. So these are early indicators of developmental deviation. When you are not aware of what is happening around you, your understanding will not develop in a way that it should develop. And that is the whole meaning of early intervention. She's showing the ball. Usually what parents do is they show things the child is interested in, and that's how they communicate. And they think, response ho raha hai. But overall, if there is a gap, then they need diagnosis. This is my family from, I think they are living in Dubai, yeah. So they came because they said, oh, the child has ADHD and everything. So I said, no, it's not ADHD. So, yeah. Okay, let me see if this one works now. Okay, so this is a child, again, with cerebral palsy, walking on the tiptoes. The video is not working, but if there is time, I'll show you in the lunch. Okay. आप कर सकते हो. Okay, so this video is showing a child with low tone. So whenever you see a child with low tone, they will walk with their legs spread. They will try and make balance. So you just need to look at their gait to say, are they walking toe heel? Are they walking with the right balance? How is their feet when they touch the ground? So all of that are very important observations that we do in our clinical examination that gives us an idea. Everything is just looking at the pattern. Anyway, so vision-hand coordination. Look at your child, how is their vision-hand coordination? Vision-hand coordination all develops together. If the vision is deficient, they will have deficiencies in fine motor skills. Sometimes the teacher are worried about the handwriting and stuff, but basically look at their posture, how they are sitting. So if they are sitting like this, if they are not holding the pen properly, the problem is that they haven't got right stimulation for their larger muscles. Develop good posture and good confidence in your child. Some of these fine motor activities will come. So the brain matures from head to toe and from shoulder to fingers. So if the child don't have good posture, it's the shoulder and the wrist which needs stimulation, not the fingers. So there are specific exercises for specific areas that you can do at school. And then there is reading, writing, learning. What we want is children to have a good foundation and a good relationship with learning. They should solve problems. So in classes, at home, they should solve problems together. So let's say we want to learn about Lithuania. So it's a problem. So you can go on the internet, you can go on YouTube, you can read a book, find different ways to capture information and then try and organize it, talk about it, write it. In that way, you will find a better education and a better understanding. Otherwise, they'll just learn it, next year they forget, that's it. Study will become like a... Yeah. And sometimes children have seizures. Enter. Okay. What I'll do is I'll play the video separately on Vimeo. Yeah. So for me, the most important neurological diagnosis or long-term diagnosis, does the child have intellectual disability? Very important to differentiate because the strategies are different. Or is the child neurodiverse? Plus minus, epilepsy can happen in all of them. Important to treat with less and less medicine, not to give a lot of medicine. Sometimes with intellectual disability, they can have autism features. Very important to recognize because the strategies are different. So sometimes with brain injury, they can have epilepsy, movement disorder, autism, everything. So you can have the full package. And sometimes you can have other problems like progressive neurological problems. But I'm just talking about non-progressive neurological problems. And these children you'll find in school, in primary school and stuff. So what I have done is developed a system to say, okay, if this is the diagnosis, we try and give the information to parents on the app. And then our staff is trained to talk to them. And I hope all my staff knows what information they need to capture, ask. And in that way, the word I don't like is psychoeducation. There's no psychoeducation. Diagnosis-related information. I don't like the word psychoeducation. So it should be diagnosis-related information. So I've changed it and I've said, okay, this is the diagnosis, this is the information. Okay, so what is early intervention? Early intervention for intellectual disability. So I often give this example कि मान लीजिए कि कोई रोड है जो टूटी हुई है, तो आपकी गाड़ी जो है वो धीरे धीरे जा रही है. अगर आप जल्दी से जाएंगे तो बम ज़्यादा है. तो जैसे ब्रेन में जो इन्फॉर्मेशन के लिए नेटवर्क बनी हुई है, अगर वो सही से नहीं बनी है तो इन्फॉर्मेशन स्लो ही जानी है. तो जब किसी बच्चे को डायग्नोसिस दिया इंटेलेक्चुअल डिसेबिलिटी, तो ये बता दिया कि इन्फॉर्मेशन स्लो जा रही है. अब एक कम्युनिकेशन होता है कि अब कुछ नहीं हो सकता, और एक हो सकता है कि बहुत मेहनत करनी है, बहुत सारी चीज़ें करानी है और बच्चे को सही कर देना है. दोनों ही गलत हैं. तो इसमें होना क्या चाहिए कि बच्चा जिस भी स्टेज पर है, जहाँ तक का ब्रेन बना हुआ है, उस स्टेज को सही करना है, उसके अप्रोप्रिएट एक्टिविटीज़ करनी है. तो मान लीजिए कोई छोटा बच्चा आप देखेंगे 3 महीने का, तो भी अपना हाथ पैर हिलाता है, चीज़ों को पकड़ता है और वो रिपीटिशन में करता है, तब वो नेक्स्ट स्टेज पे आता है कि वो बैठने लगता है, देखने लगता है, रीच आउट करने लगता है. फिर नेक्स्ट स्टेज आती है कि दोनों हाथ से पकड़ने लगता है, एक्सचेंज करने लगता है. तो अगर आपकी नीचे की स्टेज क्लियर नहीं है और आप ऊपर से जा रहे हैं, तो इसका मतलब है कि आप टूटी रोड पे 10, 20, 15, 20 ट्रक रोज ले जा रहे हैं, तो रोड और टूट जानी है. तो आपके बच्चे का आउटकम भी खराब होगा और बिहेवियर्स भी खराब होंगे. फिर आप कहेंगे बैड बिहेवियर के लिए वो बैड थेरेपी, वो क्या कहते हैं उसको, बिहेवियर थेरेपी. हाँ, बिहेवियर थेरेपी करा लीजिए. बट बिहेवियर थेरेपी तो हमारा ही आउटकम है कि हमने उसको आगे आगे किया. तो इंटेलेक्चुअल डिसेबिलिटी में यू शुड नो दैट विल टेक मोर टाइम, दैट्स ओके. तो जो भी स्पेशल स्कूल चल रहे हैं उनके लिए बहुत रेलिवेंट है ये. और लेवल ऑफ इंटरवेंशन इट डिपेंड्स ऑन स्टेज ऑफ ब्रेन डेवलपमेंट. और ये लिखा हुआ है, ये चीज कैसे करनी है, क्या करनी है, ये लिखा हुआ है. प्रॉब्लम क्या है कि न्यूरोडाइवर्स बच्चों में भी यही करने लगते हैं. और प्ले बेस्ड रिपीटिशन चीज़ें करनी चाहिए और एसोसिएशन सिखाना चाहिए कि अगर ये पानी है तो ये पानी पीने का भी है, ये पानी नहाने का भी है, ये पानी बारिश में भी हो सकता है. तो अलग अलग जो एसोसिएशन है उससे ब्रेन के कनेक्शंस बनते हैं, अंडरस्टैंडिंग बढ़ती हैं. समटाइम्स दीज चिल्ड्रन विल हैव एडिशनल कोमोबिडिटीज. किडनी प्रॉब्लम हो सकती है, हार्ट प्रॉब्लम हो सकती है, एपिलेप्सी हो सकती है. तो दैट मेडिकल मैनेजमेंट शुड हैपन बिकॉज उसकी वजह से भी बच्चे डिक्लाइन हो जाते हैं. ओके, सो न्यूरो डाइवर्सिटी, आई थिंक ये मूवी जो थी वो बहुत बड़ी आई ओपनर थी बहुत सारे लोगों के लिए. और व्हेन वी टॉक अबाउट न्यूरो डाइवर्सिटी वी टॉक अबाउट स्ट्रेंथ एंड वीकनेस. वी शुडंट से दैट द चाइल्ड हैज नो स्ट्रेंथ. एंड देन लर्निंग प्रेफरेंस क्या है, कैसे उनको याद रहता है, देख के याद रहता है, सोच के याद रहता है, पढ़ के याद रहता है. देयर हैज टू बी सम लर्निंग प्रेफरेंस, उसको पकड़ लेना है. और उनके मोटिवेशन इंटरेस्ट क्या है, और बच्चे से ट्रस्ट बदलना है, क्योंकि ये बच्चे ट्रॉमा में बहुत जल्दी आ जाते हैं. लेकिन उनको याद रहता है छोटी छोटी बात कि 25 साल पहले आपने ऐसा किया था. तो सो ट्रस्ट इज वेरी इंपॉर्टेंट. एंड व्हाट वी वांट कि वी नीड अ गुड अंडरस्टैंडिंग ऑफ वर्ल्ड पीपल एंड सिचुएशन. सो जो मैंने अर्लीस्ट फाउंडेशन स्किल बताया था यूके का, उसमें दिस इज इंटीग्रेटेड इन द करिकुलम. सो जो अभी करिकुलम की बात कर रहे थे, देयर इज अ नाइस करिकुलम, यूके करिकुलम, जो आप यूज कर सकते हैं. एंड यू कैन हैव असेसमेंट ऑन दैट एंड यू विल नो, यू विल फाइंड कि अच्छा ये क्या है. तो अंडरस्टैंडिंग द वर्ल्ड एंड पीपल डोमेन इज द मोस्ट इंपॉर्टेंट डोमेन फॉर एनी चाइल्ड इफ यू वांट इंडिपेंडेंस. उसके बाद न्यूरो डाइवर्स चिल्ड्रन में यूजुअली प्रॉब्लम मेंटल हेल्थ की होती है. सो लेटर ऑन, जैसे आप लोग मैथ्स में देखते थे ना इक्वेशन a+b = c+d, इट्स अ बैलेंस इक्वेशन. न्यूरो डाइवर्सिटी इज एन अनबैलेंस्ड इक्वेशन कि a+b आप कर दोगे, c+d भी आ जाएगा, मगर जो बचेगा वो एंग्जाइटी बचेगी, डिप्रेशन बचेगा, साइको. Vas is my epilepsy nurse in London, so he is joining, और ये स्कूल की ट्रेनिंग कराते हैं. So Vas will be telling us कि वहाँ यूके में स्कूल में इंक्लूसिव एजुकेशन कैसे देते हैं. So we will talk about that. और चलेगा. हाँ. So very important that not all seizures are same, not all epilepsy is same. Some seizures don't need medication, some seizures need specific medication. और देर इज़ अ वेरी क्लियर गाइडेंस ऑन इट कि बच्चों में क्या करना है. तो अगर कोई भी बच्चा 3-4 एपिलेप्सी की दवाई पर है तो उसका आउटकम तो वैसे भी खराब हो गया. सो वेरी इंपॉर्टेंट कि उसको सही से असेसमेंट हो, एवेल्युएशन हो और सही से ट्रीटमेंट हो. ओके, सो सम चिल्ड्रन विल हैव इंटेलेक्चुअल डिसेबिलिटी, सेरेब्रल पॉल्सी एंड ऑटिज्म. देयर वाज वन प्रेजेंटेशन ऑन सेरेब्रल पॉल्सी जिसमें उन्होंने बोला था कि हर बच्चे सेरेब्रल पॉल्सी में ऐसा नहीं कि फंक्शनल नहीं होंगे. तो 50% बच्चों में इंटेलेक्चुअल डिसेबिलिटी नहीं होती है. 50% विल गो टू नॉर्मल स्कूल बिकॉज उनका ग्रे मैटर डैमेज नहीं हुआ. सो टुडे आई हैव अ सेशन जिसमें मैं दिखाऊंगा कैसे देखते हैं कि बच्चे में इंटेलेक्चुअल डिसेबिलिटी होगी कि नहीं, वो पहले से बता सकते हैं आप. और अगर बच्चे में कॉम्बिनेशन है कि सेरेब्रल पॉल्सी भी है, ऑटिज्म भी है, या इंटेलेक्चुअल डिसेबिलिटी भी, ऑटिज्म भी है, तो सिखाना बहुत मुश्किल होता है. वो करना ही नहीं चाहते. आप सिखाओगे तो अगर आप बगल में एक स्पेशल स्कूल है वहाँ जाओ तो देखो बहुत सारे बच्चे ऐसे हैं जो अपने अपने बैठे हैं, कुछ कुछ बोल रहे हैं, कुछ कुछ कर रहे हैं, उनकी कुछ कुछ ऑक्यूपेशनल थेरेपी चल रही है, वो अपना चली जा रही है, सालों साल चल रही है, मगर कोई उसका बहुत आउटकम नहीं आ रहा बिकॉज उन्होंने सही एरिया टारगेट ही नहीं किया हुआ है. सो यू हैव टू से कि एक्टिविटीज़ किस तरीके से कर रहे हैं. तो कराई जा रही हैं एक्टिविटीज़, क्या वो प्ले बेस्ड हैं या कराई जा रही हैं, तो क्या अंतर है. जैसे आप लोग मेरे पास आए हो और अगर हम बोलें कि नहीं हम लोग यहाँ पे कैरम खेलेंगे, तो आप बोलोगे नहीं हम तो यहाँ पे आपसे न्यूरोलॉजी पढ़ने हम कैरम कैसे खेलेंगे. तो फिर नहीं, आपको खेलना पड़ेगा तभी मैं बताऊँगा. तो शायद आपका इंटरेस्ट उससे डेविएट हो जाए कि नहीं मैं ऐसा नहीं करना चाहता. तो बच्चों में क्या हो रहा है कि ये सेट एक्टिविटीज़ हैं. एजुकेशन करिकुलम पहले से सेट कर दिया गया है कि क्लास में आओगे तो यही करना है. और जब बच्चे को वो चीज़ नहीं मिलती है तो उसका अटेंशन स्पैन नैरो होने लगता है. तो अटेंशन स्पैन का मतलब क्या है कि मिलियंस ऑफ न्यूरॉन्स आपको बता रहे हैं कि आसपास क्या हो रहा है, और कौन सी चीज इंपॉर्टेंट है वो फ्रंटल लोब से आता है। तो फ्रंटल लोब डिसाइड, अक्सर ये हो जाता है कि फोर्सफुल एनवायरनमेंट में बच्चे को एंटरटेन किया जाता है। तो जिन बच्चों में ये प्रोफाइल है कि इंटेलेक्चुअल डिसेबिलिटी, सेरेब्रल पल्सी और ऑटिज्म, उसमें आप ये नहीं करते। फिर कुछ बच्चे ऐसे होते हैं जिनके पास मेंटी है, उनको दिखाई दे रहा है, थैंक यू। सो कुछ बच्चे ऐसे होते हैं जिसमें बिना कारण के बच्चे का बॉडी टेढ़ा हो जाता है, या बिना कारण के बच्चे का हाथ पैर जो है वो मूव करता है। तो मूवमेंट डिसऑर्डर्स होते हैं जिनका रिकॉग्निशन इंपॉर्टेंट होता है। और अगर नहीं होता है ऐसा तो बच्चों को क्रॉनिक पेन होता है। जैसे मान लीजिए किसी रिक्शे वाले से पूछे कि आपको क्या शरीर में दर्द होता है, तो कहेगा नहीं साहब, वो तो रोज ही करता है, बट उसको क्रॉनिक पेन है। तो जब वो बंद कर देगा तब उसको समझ आएगा कि हाँ दर्द तो होता था, पता ही नहीं चला मुझे। तो क्रॉनिक पेन, एब्नॉर्मल पोस्चर और इम्पेयरमेंट ऑफ फंक्शन तीनों हो जाते हैं। अगर स्पाइन का पोस्चर सही नहीं है तो फाइन मोटर डिफिकल्टीज भी हो जाती हैं। सो उसका भी काम हम लोग देखते हैं। सो ये फाइनली एक स्लाइड है, इफ यू कैन सी, इसको मैंने कल ही लिखा। टू चेंज द वर्ल्ड यू डोंट नीड टू सेव एवरीवन, इफ यू लिफ्ट जस्ट वन चाइल्ड यू हैव फुलफिल्ड अ पर्पस दैट इकोज फार बियॉन्ड योरसेल्फ। तो यही मैं बोलना चाहता हूँ कि अगर आपकी वजह से एक भी लाइफ चेंज होती है, सो यू हैव डन समथिंग एंड दैट शुड बी द पर्पस। बाकी सारी चीजें मैटर नहीं करती हैं। थैंक यू वेरी मच। सो अभी मैं आई विल पास द डाइस टू Vas, who's woken up so early, and basically it's night there. So नाइट का मतलब अभी 7 बजे वहाँ नाइट ही होता है। विंटर टाइम में टेक्स अ लॉन्ग टाइम फॉर द सन टू कम। आपने वो जोक सुना होगा कि आज सूरज निकला है इंग्लैंड में, तो यू नो। हेलो वैस। Yeah, so you can see me, but everybody can see you. So I can change my thing in a separate direction, so you can see everyone. No, you've got 2 cameras, so that's good. So we are all ready for you, Vas. So you can give a short introduction and then carry on, and we'll increase the volume. Can you please increase the volume from the thing? Yeah. Okay, Vas, we are ready for you. I'll take a break. Sorry, the sound is not clear. The sound is not clear, Vas. Yes, maybe that will work. Yeah, put it more close. Yeah, better? Yeah, it's maybe a bit more loud. No, okay, children will wake up. Yeah, children will wake up, okay. तेज हो पाएगा और कुछ तेज हो पाएगा, यही रखो. That's it. ठीक है. Okay, try Vas now. कैसे होगा? वहीं से होगा. चलो ये भी रखो.
Okay, thank you. My name is Vas and I'm the epilepsy nurse working with Dr. Barab. He called me here to discuss about the epilepsy presentation, but we give to teachers and parents when they deal with a child that has epilepsy. So what I have done is I'm not going to give you the same presentation, but I'm going to show you how to make the presentation according to the standards, and obviously you can adjust that based on your needs and on your own numbers, and I'll explain what I mean by that. So let me share my screen. Okay, you guys can see that? Hello?
Yes, we can see.
Okay, fantastic, thank you. So we're going to discuss about how to make the presentation as I told you before. So the presentation we do is not up to us completely. It has there's some essential components and some desirable components that need to be according to the ILA, which is the International League Against Epilepsy, the BPNA, which is the British Paediatric Association on Epilepsy, and also the ESNA, which is the national organization which focuses on epilepsy. So in order for the presentation to be according to the standards, and this also includes legal liability on us, we need to have include specific topics. So what is epilepsy awareness, what is epilepsy, what can cause epilepsy, diagnostic tools, different diagnoses, types of seizures, treatment options, what is status of epileptic risk assessment, and all that you guys can see on the screen. So I'm going to take it step by step and show you how we have put them all into a presentation. So when we discuss what is epilepsy, obviously everything has to do with who is your audience. So if a child is, if you're talking to a family, you need to have a different approach than when you're talking to school, or when you're talking to different healthcare professionals. So we, on the definition of epilepsy, we're just following the International League Against Epilepsy, but we talked a lot about the febrile seizures, and this is the most common misconception in UK. So people that they see a baby that has febrile seizures, they often confuse it with having epilepsy. So we split those two cases right from the beginning, and we explain what the difference and how this can affect people. Also, we need to mention that epilepsy is a lifelong condition, and again we have the international data where it shows that people with epilepsy, the seizures are going off after the age of 18 to 20, but the majority of them are coming back after the age of 55. Then again, for what is a seizure, we're using the definition of the International League Against Epilepsy, so nothing extraordinary. And based on their audience, we explain to them in layman terms how do you think, how the nervous system is working. So if you're talking about some family or some parents, then you can specify the example based on the case you have in front of you. Otherwise, we just give them like how the nervous system works with electricity in the human body. Then we go into demographics and epidemiology. Again, this it will depend on which region you're giving the presentation to, so you need to update the numbers. And I have some numbers here for UK. So in UK, epilepsy is the most common neurological condition. We're treating 1 in 100 people and 1 in 220 children. And then because my audience is, my workload is based on people with autism and cerebral palsy, we know that they have an additional epidemiology rate on epilepsy. So the risk is going up to 70% for those kids instead of 1%. So again, based on your on the region, you need to update the demographic data. Then when it comes to causes, if you're talking to a family, then that's fine. You only consistent conversation, you only deduct the subject on the specific case. If you're talking to a community like I was talking to a Muslim church, like a Muslim mosque the other day, so we explained a bit the genetic and culture of isolation and how the culture of the Muslim community, by getting married into the family, they tend to have carried the genes for epilepsy, and some of the families, they tend to have a higher percentage and a higher risk for epilepsy than others. And again, we admit the fact that more than half of the cases, and for that in the case around 78%, we don't know the cause of epilepsy. And that's a more difficult part when we speak on the family, and if you don't know why the child is having epilepsy. Then we go into the diagnosis. We have a lot of objections from parents to say, prove me that the child has epilepsy and show me where you see the epilepsy and why you start the treatment. And it's super difficult for them to understand that in 2024, we don't need any test and we cannot have an exclusive test to prove epilepsy. So only the witnessing from people to say that the child had 2 or more unprovoked seizures is enough for us to start the treatment. And we try to explain to them what the supporting investigation we've done have told us, and why is that important into the epilepsy picture, and what the result means. When we are talking to a school, this is because 67% of the data we get about kids having seizures is coming from school, because they're spending more of their daytime in the school environment, so the teachers are like second parents for them. So we explain to them how important is that information and how they help us to give the diagnosis of epilepsy. And we talk about best practice of giving evidence, and if we need to, we speak with the school to change the policy and allow videos to be taken of the students. According to the UK policy here, this is a bit difficult, and the new GDPR law is not new anymore, but the GDPR law has become an issue, and not all schools are withdrawing the new policy. But again, with parental discussions, we try to bring the practice back into the schools. Then we go into mortality and morbidity. So on this subject, when it comes to the families, if the child has autism, for example, and we discuss about mortality and morbidity, personally, I give the child a task to be in the living room just for avoiding the extra stress. If you think that the child is mature enough to take this conversation, then you sit them down and you talk to them. It's better actually to find out from you than find it out from Google or YouTube. So again, region rates are different from country to country. So in UK, the mortality is 30% higher than the general population due to injuries and accidents. We talk about SUBIP, and our data shows that it's 1 in every 5,000 children and 1 in 2,000 adults, again in the UK. And those data come from SUBIP action. And we're talking about the status epilepticus and how they can avoid it by using rescue medication. And it's very important for them to understand why by giving a rescue medication they can prevent the child from going to status epilepticus, and how they can help saving its life essentially at some point. And then we discuss about quality of life. So a lot of children are set in some decisions from young age. For example, somebody wants to become a pilot, and you need to let them know that he cannot become a pilot for obvious reasons. So again, this is, if you're talking to family, it's better if you focus on the child and make it like a participation conversation, like what do you think, what you want to do in life, and then explain what the difficulties will be and how they can overcome them if they can. Also, you need to explain to them that if epilepsy will be not treated, then you might have to do a lot of regression, and how the medication is going to behavior and learning of the child. Then we go to the different...
Wes, sorry, your slide is not changing. Can you just go on slide share? Go on slide share, yeah. Thank you.
Sorry, I do apologize. Can you guys see me? Dr. Mark, can you see?
Yes, we can see the slide. Is it really possible to go on slide share and just make it like one big slide? Go on the slide share.
Is that okay?
Still I can't see the whole slide. The slide share. Just go on the presentation. You are on the home. Just go up. Next to design.
Guys,
We're still there. Just saying, if you go on the top head next to home, there's slide share. Go on the slide share. Slide share. 1, 2, 3, 4. Next to animation. If you go on slide share and just say present from current slide, wherever you are. One more time. Yeah, we can see, but the whole slide is not coming. Anyway, let's leave it there. But I think it's not coming. Still not coming. Wes, can you just get? Can you see the whole screen?
yes, I can on my side, yes.
Okay, So hopefully, if it doesn't move, then I will let you know. Carry on.
Okay.
Thank you.
So as we were discussing, we go to activities and we tell them how they can participate in the activities in a safe way and what prevention measures can we take against an accident. Then we talked about stigma because we have a lot of people that they don't say the diagnosis of epilepsy because they're afraid of being stigmatized or the child will be stigmatized. And in that way, they put in risk the child because the people who is associated with those children, they don't know that the child has epilepsy. And then last we'll talk about inheritance. Again, if you're talking to a specific case and you have the data to support your decision, we'll talk about inheritance and what are the chances of that child to have a family and one of the children that he's going to have, what are the chances for that child to have epilepsy if it's, again, something we know. Is the slide changed now? Can you see on the, there we go? Okay, so
No, for change of slide, just click on the slide number, like go from 10 to 11, it will change. Go to 11. Yeah, perfect. It's working. Just change on the slide number, it will work. Thanks, Wes. Yeah.
So when it comes to treatment, when we are talking about a 6-monthly review, which can be done in nursing care or the doctor, we're talking about the medication and the different types of medication. And then if you're speaking to a family, we can focus on the side effect on the specific medications. If the child is on soluble to pyramid risk, then we need to do the assessment, the risk assessments. And those risk assessments in these days are mandated legally from the UK. So we need to expand on the prenatal test that the patient needs to do, how they can stop it when they need to become pregnant, and testicular toxicity for the boys, and all that. It needs to be assessed if we put the child in soluble to pyramid. And then we talk about congenital and BMS. Again, if it's a family, only if it's applicable to a child. If it's a school, we need to go through it because they will have somebody on congenital or BMS. Then we go to the types of seizures. So we start with the focal seizures. What are the focal seizures? What are the different symptoms that they can express themselves with? What is oral and how a child, which is, for example, non-verbal, will react when he knows that a seizure is coming to hit him, and what is the behavior you're going to see behind it. We talk to them that why we treat the focal seizures of this specific child and why we don't treat it on another, and if there's an evidence of the focal seizures expanding and becoming generalized seizures. Usually we show them something like that for visual input, so they can understand that we know where the seizure is coming based on the symptom the child is showing, especially when it comes to schools. Because we are heavily relied on the witnessing, and we need the witnessing in order to make treatment changes and in order to make to provide a better care for our patients. So we explain to them why it is so important for them to have like adequate notes and, if possible, to take video. And this is how usually they perceive the difference from one season to another, and how important it is to tell us exactly what's happening. When we go to the generalized seizures, we talk about fatality, and again, when you're talking to school, they need to understand the importance of the emergency medication use and how they offer and how they prevent fatalities from happening by using it. And then we go to different generalized seizures, and we try to talk to them about the tonic-clonic, atonic, and all that seizures. But in the essence of it, when you guys talk to the school, when we're talking to the school, we try to tell them, we don't care how you call it any way you like, we need the description, we need to tell us, and if possible, show us what you saw on the child. Then we go to triggers, especially when it comes to teenagers. We expand on the alcohol and drug use. As you guys know, London is heavily impacted by drug use in the teenage years. We're talking about missing meals if we step and all the triggers that the child can have, and we focus when we speak to a family on specific triggers that it can be common to a family. For example, late days, we have sent some complaint letters to a company called Steam on the internet, because this is what the main platform the kids are using to download online gaming. The problem with the platform is that they don't give them the epilepsy warning on the games. So if you buy a game from the video shop, there will be a sticker where it says, please do not use epilepsy, danger of flashing lights, etc. When you download it from the platform, you get absolutely no warning. So those are the different, again, territorial changes that you guys need to look into and figure out how you guys can apply it. Then we go into a simple do and don't when a child is having a seizure. And usually, if I'm talking to school, I'll put one of the teachers on the floor and we pretend that he or she having a seizure, and we say what you do and what you don't do. When we call for help, again, this depends and changes from doctor to doctor, from region to region in London. For example, in South London, they don't ask for help unless the child has breathing difficulties. In our population, we ask them to call for help immediately as the medication is given, because our population is, we have children with cerebral palsy, and those children, their respiratory drive is already reduced and heavy, so if you give them back in the bathroom, you can cause them problems. So again, this needs to be done, you need to have the risk assessment on your own and explain to the family and the school what you want to do and when you want to call for help. And then we're talking about the care plans. So in UK, for every child that has a rescue medication, we need to do a different care plan, like an individualized care plan. The reason for that is for each child we treat and not treat different kind of seizures. And it's important for the school to have an individual care plan for every child in the school that has epilepsy and is on a rescue medication. Again, we need to remind them the importance of those plans to be updated yearly. Then we go to all the different types of rescue medication. Again, if you're talking to a family, you only focus on the rescue medication the child is on, and you move on from that. You don't need to go through the whole thing. In UK, the majority of the patients, like 99%, are back on the bathroom. So we go into the risk of background background use. I'm aware now that you guys are giving nasal spray, background nasal spray, which is the same associated medication, the same list, but it's different administration technique. And yeah, basically you need to go when you talk to families on a specific rescue medication. But if you go to school, you need to change the presentation according to rescue medication, that the majority of children are on the medication. And the second thing is, if you have children that they are on parentaldehyde, or if you have children that they are on diazepam, then they will need a different training on how to react on those children when they have a seizure. We have a lot of visual inputs, so as I said, different medication in the UK, and then we go to the safety checks and risk assessment. So for every child that has a rescue medication, we need to do these checks whether we get the medication into the school, and if any of that is not according to what is prescribed in the care plan, then the medication cannot be administered to a child. In that case, obviously if something happens to a child, they call for 999 straight on, but this is what we check every time they bring medication into the school. Then we go into detailed description of how to administer the medication, and we emphasize, because we had several accidents in the last 5 years, to not put anything between the teeth of the child. We have some nasty accidents over the 5 years, and we emphasize a lot of that, and we put some demo pictures, as you can see, on how to use the background safely. Again, if you use the nasal spray, then you need to explain to them how to administer it, and what are the risks of something of not administering correctly. When we go into what to expect when we administer the background and what are the risks of this child when they receive the background. So again, we go into different times, which is this is global. Like for example, we will start working after 5 minutes and terminating the series in 10 minutes. We need to clarify to them that the 98% of the seizures are stopped, but the 82% will continue to be seizing, and they need to act on the best interest of the child and move on the care plan. We expect them this Georgie, and the most important thing is that they need to document the time they gave the medication. The reason for that is because when that list comes through, we need to continue the start support to this protocol. So if you don't know what time they give the medication, then they will be in a different position. And when we go through all that, we run a small scenario, and one of the teams will present what they do, as I said, one will be on the floor, and we will act like the child is having a seizure. What is the rest of the things going to do, how are we going to help the child on the floor. Then we go to the risk of background as well. We know that 1 in 3,500 people that get background will start having breathing difficulties, and 1 in 20,000 people will stop breathing. This is undisputable data, and we explain to them that despite we have done a risk and benefit analysis here, and we still think that you should give the background to the children. And we explain again the fatality of the stem cell epilepticus if it's not treated on time. And we offer them some of the resources which are available in the UK. Again, depending on the region you're practicing, it's always better because when you speak to the public, we give them more resources to go on, because you might be the best lecturer in the world, I know I'm not, but they might not take everything in when you finish. So when it comes to us, and if a child has the capacity, we divert them to young epilepsy, which is young people with epilepsy writing about themselves. So it's easier for them to approach it, it's easier for them to understand it. So give them as many resources as you can. Best way now these days is electronically, so text or the email will do the job. And hopefully after finishing the presentation, you will be able to collect the desirable effects. And hopefully people provide the rest communication safely. So let me go out. Okay, thank you guys for listening. Sorry for the practical difficulties. Yes.
The technical difficulties, I think we were able to gain something out of it. Any questions from anyone? The practice of epilepsy, of what we're doing, there's a lot of work that we need to do. So maybe you can talk about sodium valproate and what is the issue going on with sodium valproate.
Yeah, I don't have a presentation, but I'm happy to talk about it.
Just a little bit about the risk and what's happening.
Yes, as you guys know, as a medics, the sodium valproate is associated with malformations in the prenatal age of the child. So we have a strict law now in these days in the UK, where it says that we need to avoid the sodium valproate and to pay the prescription on any young child younger than the age of 55. Back in the day, was only the female patients between the age of 9 and 55. These days, we are going to prescribe sodium valproate to on any child younger than age, or any person younger than age of 55. If we have no other solution, and we need to prescribe them either for mental health reasons or epilepsy reasons, then we need to complete a legal assessment form. And this is a risk form where we stipulate and we have discussed this risk with the patient, we have explained that there isn't any other solution, and this is why we prescribe the sodium valproate to the child. Also, it needs to be prescribed and co-signed by a second consultant. And the second consultant will verify that every other solution has been examined, and the sodium valproate is the best way to treat this child. The reason for that is that you cannot bear the legal responsibility on your own when you prescribe sodium valproate, and if something goes wrong, you will be liable if you don't follow the protocol. So this is happening in the UK, and as I said, it's a legal requirement, and we need to have this risk assessment done yearly after the child has broken the period. We need to discuss yearly with the child and the parents about the risk of sodium valproate and topiramate. These discussions are audited by NHS England, and as a result, we are liable, and there's very hefty fine if you don't follow this practice. So things are changing. I know, for example, in Greece, sodium valproate is the best way and the first line medication we prescribe when somebody has epilepsy, because it knocks out everything, and usually you don't see another seizure. But these days, with prenatal anomalies and testicular toxicity, it has been thrown out of the window, unfortunately.
Run now.
I've done my running, yeah. Thank you guys, thank you for having me, and all the best to your conference, thank you.
इससे बस यही मैसेज देना था कि एपिलेप्सी वर्ल्ड में चीज़ें बहुत तेज़ी से बदल रही हैं, और इवन फॉर सोडियम वैल्प्रोएट बिकॉज ऑफ साइड इफ़ेक्ट प्रोफाइल बच्चों में बहुत केयरफुली देने का रिकमेंडेशन है। और घर में अगर सीजर आते हैं या स्कूल में सीजर आते हैं तो उसके लिए केयर प्लान्स अवेलेबल होते हैं। और हमारी कोशिश रहेगी कि बच्चों में जीनियस लेन में हम ये केयर प्लान इंटरनेशनल स्टाइल में इंटीग्रेट कर सकें, ताकि जिन बच्चों को सीजर आते हैं वो स्कूल उनका गैप नहीं हो। मैंने अक्सर देखा है कि अगर बच्चे को सीजर आए तो स्कूल बहुत हेजिटेंट हो जाता है कि हम बच्चे नहीं लेंगे। तो ये बहुत इम्पॉर्टेंट है कि बच्चों की स्कूल का गैप नहीं हो, इसलिए कि बच्चे को सीजर आते हों। तो ये भी हमारा एक मिशन रहेगा आने वाले समय में कि बच्चों में अगर सीजर आए चाहे ना आए वो स्कूल जाने चाहिए, और स्कूल के पास एक अच्छा प्लान होना चाहिए कि अगर सीजर आए तो क्या करना है, जो बहुत ही सिंपल है, जो बाहर के देशों में हम आराम से कर पा रहे हैं और यहाँ भी हमें करना चाहिए। और दवाइयों को लेके भी बहुत पॉपुलर दवाई है सोडियम वैल्प्रोएट, जिसको लेके अभी साइड इफ़ेक्ट प्रोफाइल की वजह से चीज़ें थोड़ी सी चेंज हो रही हैं, और आई एम श्योर 1 साल 2 साल में यहाँ भी रिकमेंडेशन आ जाएगी। तो हमें अभी से उसकी तैयारी करनी है कि चीज़ें बच्चे अगर उन दवाइयों पे हैं तो हम उनको दूसरी दवाइयों पे चेंज कर सकें। ठीक है, थैंक यू सो मच। अब मैं नेक्स्ट मेरे ख्याल से स्कूल का है, कौन? हाँ, आप इंट्रोडक्शन दीजिए।
Thank you so much, sir. Now we have one school here, Kids Say, and her principal is
कौन सा
So this PPT, that one, pantomime.
ये वाला?
Yes, yes.
इसको लगा देते हैं,
She's
शेयर कर देते हैं। बस इसमें बस आपको ऐसे ऐसे करना है, फिर आगे बढ़ते चला जाएगा।
Hello everyone, my name is Richa Manwani and I am from Kidsy Preschool. So I started my journey with Kidsy in 2014, and as all doctors are here and special educators are here, I don't have that much knowledge about special children, but we've started taking admissions since then, just doing our little bit to change at least one life. So I will tell you about the pedagogy which we use at Kidsy. So first of all, we have multiple intelligence at Kidsy, developed by a psychologist named Howard Gardner in 1983. So he suggested that intelligence is not single generated ability, but rather collective of different types of intelligence that people possess in varying degrees. So this is what we practice. We have different sessions in schools based on these activities. The curriculum at Kidsy is called Pentamind, which works on 5 minds of children, which is scientifically designed, and I will just give a brief about these minds. So first is focused mind, which needs full attention and energy to do a single task or thought, blocking other distractions. So we have activities related to focused mind like whirl and twirl. That is a dance activity. This helps the children to synchronize their mind, to synchronize the action with the space given and the body actions. Then we have analytical mind, way of thinking characterized by ability to socially examine information, identify patterns, and break down complex problems and assess situations in structured manner. We have activities based on this also. We have books on analytical mind. Then we have inventive mind, creativity, originality, and ability to think out of the box. For this we have showstopper session in which it is basically drama. So in this we give children the situation or a prop or an emotion wherein they have to act accordingly. Like they have to use their mind. So people with inventive mind are skilled at generating new ideas, imagining novel solutions, and approaching problems in unique ways. Then we have empathetic mind that deeply understands and shares the feelings, thoughts and perspectives of others. So we have mental mind books where before doing any activity, children are making affirmations like I am confident, I am special, so that they start loving themselves, then only they will be able to understand others' feelings. Then we have conscientious mind, part of awareness responsible for our active thoughts, perceptions and decision making. Aspect of mind that we use to focus, analyze and reason, that make choices in real time. So we have artsy session for this. We have different books of artsy wherein they have different form of arts like Madhubani art and modern form of arts and ancient form of arts. Then they do messy arts also, wherein they put their thumb at the bottom just to make them confident that yes, this is done by me. So there are 26 different sessions conducted throughout the week based on these minds only. So from our end, this is what we are doing. So strategies which we are using at Kidsy. First of all, when we are taking admission of special children, there is a C-bar form which is being filled based on their behavioral actions, whatever they are doing in school. So we fill this form and send it to the academic team. Zealand has a great role in this. Then we have special educators in school who help us in making individualized education plans for these children based on the our curriculum only. This is done by special educators. We have a special educator in school. She provides pull-out sessions to children, one-to-one support or small group support. Then we have teachers training, which is done by academic team from Zealand. They help us to understand the needs of child and their behavior through those C-bar forms. Then accessible learning materials like talking pens. Then we have visual aids. This is what we practice for special children. Sensory friendly spaces we have in school. So wherein children can take breaks to manage sensory overload, reduce anxiety and self-regulate. Then we have inclusive teaching methods like flexible children who are absent in home column, so that social interaction is like made. Then family engagement and collaborations. We collaborate with the families, ask them about their workshops for parents also by our academic heads. Then we focus on social emotional learning, which is essential for all students but especially helpful for children with special needs. This helps them manage emotions, build resilience and develop positive social skills. So by implementing these practices, we are creating a nurturing environment that fosters academic growth, emotional well-being and social development for all students, including those with special needs. So right now we are having around 12 to 14 children with special needs, around 2 in each class, and we are doing our little bit to help these children. That's it. Thank you.
So if anyone has any questions, please. Anyone has any question? Any question? There are some parents here. Do you have any questions? Thank you so much. I'm really delighted कि इतना मतलब they have got a good curriculum and very similar to what we are doing. There are some bits I'm sure that we can do together and help more children. So I have decided that we are going to train all the teachers in your Kidsy and I'll give my course to them. I've already told Neha, so she'll coordinate that. Thank you. So now it is going to be lunch time in a few minutes. I was told that 1:30 lunch will be ready. It's ready, okay. So lunch is ready. So please come back at 2:30 for everyone who want to join the workshop. So I just want to say that the workshop is continuous, 7 sessions, half an hour each. So that's 3.5 hours. So if you need water break, water will be there. If you need toilet break, just go out of the group. Do does everyone who is joining the workshop know their groups? Were you given group A, B, C, D? No? Okay, we need to tell you. So basically what will happen is that you will be in a group, you will go to like workstation 1, then that will finish, half an hour, the buzzer will go, workstation 2, workstation 3, there will be like 7 workstations, you will go around. Usually 2 of them there is no sitting, rest you can sit. Usually my workshops are no sitting anyway, so you can walk and do it, but in this it's like that. But it's very good, designed to now practice everything that you have learned. Okay, not my phone. Okay, so yeah, so we can go for lunch, and when you come back, how do we give the group to you? No, we have to let them know now, otherwise how will? Yeah. So who is staying for the workshop? Everyone? Everyone's staying. So yeah, we need to let them know now. So the leaders, do they know their group? Everyone? The name is there. So if any of the leaders forget what they're doing, the name is on the thing. Okay? Yeah. So it's only 7 workshops, but everything is different. Autism is there, cerebral palsy is there, how to understand MRI is there. It's relevant for everyone. Dyslexia is there. But they should have printed at the end. कोई बात नहीं, हाँ बता दो. So you can see your group. Shall we leave it on and you can just come and see your group? Everyone there?
Everybody is there.
All the things. And ये तो move करना पड़ेगा ना? तो कैसे करेंगे? Okay. So I'll just say, इसको print कर दें क्या? Yeah. Okay. So group A, I'll just very quickly say, Ritesh, Shekhar, Riya Kapoor, Soumya, Anush, Adam. Best is I will just print it and you can just see which group you are. Okay. Okay, yeah, please go for lunch and we'll see you at 2:30. Where is the lunch? Where is lunch? बता दो.
Please come.
ठीक है. तो किसी को अगर नहीं पता कि वो कौन से ग्रुप में है तो प्लीज हैंड रेज कर लीजिए. अपना नाम बताइए. आर.के. सिंह. दिक्कत हो गई.
एक चलो बोल देना, हमें तो ज़्यादा अच्छा है, फटाफट बोलेंगे.
आप बोल दीजिए.
ग्रुप ए में है शेखर कपूर, रितेश, शेखर, रिया कपूर, सौम्या, दर्शन, अनुष, अदनान खान, डॉक्टर वगीश अवस्थी, हर्षी एंड राहुल. इतने लोग ग्रुप ए में है. ग्रुप ए मीन्स इधर ये वाला नंबर 1. फिर से बोल दूं, ग्रुप ए रितेश, शेखर, रिया कपूर, सौम्या, दर्शन, अनुष, अदनान खान, डॉक्टर वगीश अवस्थी, हर्षी एंड राहुल. इतने लोग हैं ग्रुप ए. ग्रुप बी मीन्स उधर है, वर्कशॉप नंबर 2। देवेंद्र मिश्रा, शिखा मिश्रा, निशा सिंह, शिप्रा चौहान, पुनीत सिंह, राम नारायण सिंह, अदिति मिश्रा, नहीं अदिति नहीं है, बस इतना ही है, राम नारायण सिंह तक है ग्रुप बी। ठीक है, ग्रुप बी मीन्स वर्कशॉप स्टेशन नंबर 2। ग्रुप सी जो इधर है फ्रंट में सामने, ग्रुप सी में है अदिति मिश्रा, मलय श्रीवास्तव, सोनाली मुखर्जी, डॉक्टर अक्षिता एंड शंकर सूर्यवंशी। ग्रुप सी मतलब वर्कशॉप नंबर 3 एंड वर्कशॉप स्टेशन 4 यानी ग्रुप डी, अशोक कुमार पटेल, आभा शर्मा। ग्रुप डी में है आप, अशोक कुमार पटेल, आभा शर्मा। ग्रुप डी मीन्स वर्कशॉप स्टेशन 4 उधर है। ग्रुप डी अशोक कुमार पटेल, आभा शर्मा, रेहान नबी, आकांक्षा सिंह एंड डॉक्टर ऋचा। ग्रुप डी। ग्रुप ई, 5th वर्क स्टेशन ग्रुप ई, जयश्री विक्रम, डॉक्टर जयश्री विक्रम, डॉक्टर सिंथिया, डॉक्टर अशोक कुमार, डॉक्टर अंजलि सिंह, डॉक्टर सूरज कनौजिया, पूर्णिमा मैथ्यू, सत्यजीत मौर्य, वैशाली चौहान, आमरीन जुहा। इतने लोग हैं ग्रुप ई में। एंड ग्रुप एफ, वर्तिका वर्मा, नेहा सिंह, निखत अख्तर, संजीव कुमार, डॉक्टर पूर्णिमा मित्रा पांडे, देवांश सिंह एंड तनुजा सिंह। ग्रुप एफ यानी 6th। एंड ग्रुप जी इज रमेश, रिजवी, कयूम, डॉक्टर शुभांगिनी, डॉक्टर अरविंद यादव, डॉक्टर संजीव, आराध्या वर्मा।
हेलो, हाँ, तो जो भी ग्रुप में है वो शुरू कर दें। आप लोग प्लीज बातें नहीं करिए, जिस भी ग्रुप में है शुरू कर दीजिए। अगर आप किसी ग्रुप में नहीं है तो फिर इधर सोफे पे बैठ जाइए यहाँ पे। हाँ, स्टेशन 6 पे कौन है? वर्मा, नेहा सिंह, ये सब जाइए ग्रुप 6 पे जाइए प्लीज। वर्तिका वर्मा, नेहा सिंह, निखत अख्तर, संजीव कुमार, पूर्णिमा मित्रा, देवांश, तनुजा सिंह। आप लोग सब लोग जाइए ग्रुप 6। ग्रुप 7 पे रमेश, डॉक्टर शुभांगिनी, डॉक्टर अरविंद यादव, रिजवी, कासिम, डॉक्टर संजीव और आराध्या। प्लीज वर्क स्टेशन 7 पे जाइए, शुरू करना है वर्क स्टेशन 7। कासिम, रिजवी हैं? ठीक है। ग्रुप सी पे अदिति मिश्रा, मलय श्रीवास्तव, सोनाली मुखर्जी, डॉक्टर अक्षिता और संस्कार 4 लोग हैं, 5 लोग हैं वहां पे ग्रुप सी में, सब लोग हैं? कहां पर है? वहां पे हैं? नहीं है, कहां पर है? अच्छा ही नहीं है, ठीक है। तो जो भी है, अब सारे लोगों को ग्रुप मिल गया है तो मैं शुरू कर रहा हूं। ओके, डॉक्टर नीरज का शुरू हुआ? आपका शुरू हो गया? कुछ हेल्प चाहिए? मैं करता हूँ।
सपोर्ट नहीं कर रहा।
ओके, मैं देखता हूँ। आइए, कहाँ पर है? डाउनलोड कर दिया?
डाउनलोड तो हो गया।
कहाँ पर है?
उसमें होगा डाउनलोड। रुक जाओ,
न्यू करने की ज़रूरत नहीं है, डाउनलोड मिल जाए तो हो जाएगा। शिखा इधर आइए, और ये डाउनलोड कंप्यूटर में हो गया है, इसको शुरू करिए। हाँ बटिए, हाँ डाउनलोड में हो गया है प्रेजेंटेशन, उसको जल्दी से खोल दो। ये एक मिनट, हाँ एक मिनट, इसको चेंज करो, नाम चेंज करो। तुम्हारे में वो पड़ा हुआ है क्या? रीनेम कैसे होगा?
सर ये क्रोम है, इसमें ये फंक्शन नहीं।
रीनेम नहीं था, रीनेम।
यहाँ से नहीं करें होगा।
ठीक है, तो इसको ड्राइव पे लो, इसको सेव करो ड्राइव पे, गूगल ड्राइव पे। गूगल ड्राइव पे अपलोड कर लो। ठीक है, अब जाओ यहाँ पे, जाओ न्यू फाइल पे जाओ, और इस पे आओ। हाँ, फाइल अपलोड, हाँ डाउनलोड पे जाके अपलोड कर दो। चल गया, अब इनको स्लाइड से लगा देना, जब चल जाए तो हो जाएगा। ठीक है, हाँ टाइमर करना। हाँ, किसी को भी टॉयलेट यूज़ करना हो या चाय चाहिए तो यहीं अवेलेबल है।
Ladies and gentlemen, kindly switch your workshop, please. Within 5 minutes, please. Kindly switch now.
Only 10 minutes to go.
Warning reminders, everybody. Hello. 5 minutes are left. Kindly start switching.
हेलो देखो 9956
Ladies and gentlemen, can you switch to your next workshop?
कराना है का और हुआ है हुआ है हम कहीं कराना चल रहा है बस सिर्फ लाइव आइए कम कर दे तेरा बस आगे से
कोई भी 10 महीने का बच्चे बात नहीं करके
There is only 10 minutes to go. There's only 5 minutes to go. Ladies and gentlemen, kindly switch to your next workshop, please.
Kindly settle down, everybody. We are just providing the tea and snacks.
There is only 10 minutes left. Only 5 minutes to go. Ladies and gentlemen, kindly switch your workshop, please.
अरे भाई 2 मिनट ओवर।
Thank you. अगर आप मान लो डेवलपमेंटल पिरामिड है, सबसे पहले क्या डेवलप होता है एटेंशन एंड लिसनिंग, उसके बाद डेवलप होता है प्ले, या हाथ होता है साउंड होता है, तो वही अफेक्शन है, वही ब्रेन सिर्फ आपके पास है उसको वो है ना, फिर प्ले के थ्रू कई सारे स्टेजेस हैं टैलेंट के बाद इम्प्रूव होता है आपका वर्ड साउंड फिर डेवलप होता है स्पीड जो है वो कम होता है सबसे पहले इम्प्रूव होता है वही आपके सबसे पहले रेड पाथ
There are 10 minutes to work.
मैंने काम नहीं किया।
चालू है फोन कर रहा है कहाँ फॉलो है लोकेशन रह जाओ
There is only 5 minutes to go. Ladies and gentlemen, kindly switch to your next workshop, please. It's going to be your last workshop. Thank you.
Everybody, this is your last workshop. Kindly switch.
There's only 10 minutes to go. Your last workshop is about to end in 5 minutes.
So before you all go, we haven't announced the prize for the best oral presentation. अच्छा बहुत सुंदर. और सारे ही कैंडिडेट्स से मैं बोलूँगा कि माई जीनियसलेन ऐप का लिंक जरूर डाउनलोड कर लेंगे और जो भी और लोग हैं हमको शेयर करेंगे बिकॉज ऑल द इन्फॉर्मेशन इज देयर. अभिनय तो आप छोड़ दीजिए.
Can you switch to the next workshop, please?
बहुत दूर है. कदम बहुत दूर है.
Please change.
उसके बाद जाके
बैलेंस डाइट आप प्लान करवा दीजिए
चाय और खाने के लिए भी बोल सकते हैं, जितना खुशी से खा लेते नहीं करेगा तो डेवलप करेगा। ये तो पिरामिड का सबसे बेस तो वही है, लिसनिंग और इंटरैक्टिंग मतलब एक्सप्लोरिंग।
There's only 10 minutes to go.
I don't know, we are very present
Your last workshop about to end in 5 minutes.
Hello everyone, our last workshop is successfully over. Thank you so much everyone. Thank you. Please have a big round of applause for yourself only. Now we are gathering with prize distribution with closing remarks. Kindly take your position. Thank you so much everybody.
कोई फीडबैक?
सर फीडबैक स्कैनर है, फॉर्म भी है, वो बाहर लगा हुआ है स्टैंड।
So I hope this was a fun session. तो was it a fun session or was it tiring? Fun था या ठीक? Fun session तो तुम लोग के लिए fun था, मगर जो बेचारे बाकी लोग के लिए वो, मैं हमेशा ये सोचता हूँ कि if from one day आप एक चीज सीख लें और that is good enough, but I hope इस दिन में आपने 4-5 नई चीजें सीखी हो और ये देखा हो कि हम लोग की लाइफ कितनी कॉम्प्लिकेटेड होती है और कितना कुछ हम लोग को देखना पड़ता है, कितना कंसिडर करना पड़ता है डायग्नोसिस के लिए और ये सब चीज के लिए। और अभी हम लोग काफी मतलब चीजें और करना चाहते हैं ताकि बच्चों की लाइफ और अच्छी हो सके, तो आप लोग के सहयोग से हम कर पा रहे हैं। जीनियस लेन 10 इयर्स कंप्लीट कर रहा है। आप लोग जितने भी लोग आए हैं, मैं रिक्वेस्ट करूंगा कि हमारा फीडबैक स्कैनर है, उस पर जरूर फीडबैक दें ताकि हमें और मोटिवेशन मिले। नेहा फीडबैक स्कैनर प्लीज़ यहाँ पे ला दीजिए, और सर्टिफिकेट्स भी रहेंगे। और मुझे पता नहीं किसको प्राइज़ मिला है, मगर शायद नेहा बताएंगे। कौन बताएगा प्राइज़ वाला? अच्छा, किसी के कोई भी क्वेश्चन हो तो मुझसे पूछ सकता है, स्टाफ, पेरेंट्स, डॉक्टर्स। तो जो लोग नए हैं, जो लोग नहीं जानते हैं, तो जीनियसलेन का ऐप अभी काफ़ी अपडेटेड है, माई जीनियसलेन ऐप। और जो भी आपके पेरेंट्स हैं, पेशेंट्स हैं, आप उनसे शेयर कर सकते हैं। फर्स्ट इन्फॉर्मेशन वीडियो हैं और एपिलेप्सी डायग्नोसिस, ये सब आप यूज़ कर सकते हैं, आपस में यूज़ कर सकते हैं ताकि किसी को हेल्प हो जाए। अक्सर पेरेंट्स जो हैं वो सुनना नहीं चाहते हैं और बहुत ज़्यादा मुश्किल होती है पेरेंट्स को बताने में, बट आई होप कि जो इसको देखे उसको फ़ायदा हो। ठीक है, तो कोई क्वेश्चन नहीं है तो विल वाइंड अप।
Excuse me everyone, here is a scanner for your feedback for this event. So kindly scan this scanner and give your feedback once you leave, then also you can, and right now also. So we are going to announce the best oral presentation within a minute. All right everyone, so participants are ready to just know about the result. मुझे दिख भी नहीं रहे हैं participants. Kindly raise your hands. How many of you have participated? Okay. So now result is clear and is with me. So I would like to start from the, actually we have that 4 participants for oral presentation. So I would like to start with the 4th position first. So for the 4th position, goes to Dr. Richa. Please have a big round of applause, please. Please. And I would like to ask Dr. Pramod to just acknowledge with this award and certificate. Please, sir. Thank you so much. तालियां बजती रहनी चाहिए, please. Congratulations, ma'am. Thank you so much, sir. Thank you so much, ma'am. Now, the 3rd runner-up is... No, she's there. बहुत ज़्यादा उन्होंने लंबा इंतज़ार किया, उनकी फ्लाइट भी है. So I would like to call Miss Riya and Dr. Mukherjee. Please come on the stage. तालियों की आवाज़ नहीं आ रही है मुझे. Thank you. And I would like to invite Dr. Namrata, please, on the stage. Please. Certificate is coming. Thank you so much. Thank you, ma'am. Now, अगर मैं सेकेंड अनाउंस करूंगी तो फर्स्ट तो पता चल ही जाएगा. इट्स ओके. नाउ सेकेंड रनर अप इज डॉक्टर वैशाली. प्लीज कम ऑन द स्टेज. एंड आई वुड लाइक टू इनवाइट डॉक्टर टी.आर. सर टू जस्ट रिप्रेजेंट दिस अवार्ड. प्लीज सर. Congratulations once again. Now, the first prize, पता है सबको, goes to Miss Rincy and Miss Purnima. Please have a big round of applause for them. I would like to invite on the stage, please come. And to acknowledge this award, I would like to call Miss Sister Cynthia. Please come on the stage, ma'am. Thank you so much, ma'am. Please. आप दोनों इस तरफ. Congratulations, both of you. Thank you so much, ma'am. Thank you. Now, actually, we have just one school, Kidsy, and we are literally glad that she is here with us, and she is literally working very good work with kids. So I would like to invite the principal of Kidsy, Ms. Richa Manwani. Please come on the stage. And now I would like to invite Dr. Rahul on the stage to represent this award. Thank you, sir. Congratulations once again, ma'am. Thank you so much, sir. Thank you so much, ma'am. Yes. So now we have distributed that a prize ceremony is done, and I would like to invite Dr. Neeraj to just have some closing remarks for this event and just have some words for this event we have organized. Please, sir, kindly come on the stage.
Thank you, Ms. Neha. Actually, very hectic works of pediatric practice or psychologist, or you are doing a neurology practice in pediatrics. In neurology practice, if a workshop of the neurology, EP neurology, national neurology, usually जो उसका करिकुलम होता है, जो वर्कशॉप का जो पढ़ाया जाता है या जो केस कंटेंट होता है, वो बेसिकली केस ओरिएंटेड नहीं होता. इस वर्कशॉप में सारे की सारी चीज़ें केस ओरिएंटेड थी, जो कि आप डे टू डे प्रैक्टिस में डेली फेस करते हैं, और उसका निदान कम से कम मेडिसिन देके कैसे किया जाए. तो जो एपिलेप्सी है, एपिलेप्सी का इलाज बहुत ही, जो मैं हमारे यहाँ एक स्टडी हो रही है, प्रिस्क्रिप्शन ऑब्जर्वेशन स्टडी ऑन एपिलेप्सी. सुवांगिनी, डॉक्टर सुवांगिनी इज देयर, या ठीक है, ये कर रहे हैं. तो हम लोग रोज़ सारे प्रिस्क्रिप्शन जितने भी हमारी ओपीडी में आते हैं उनको कलेक्ट करके एक्चुअल डायग्नोसिस क्या है, डायग्नोसिस बेस्ड उसको ट्रीटमेंट दिया जाता है. जो एक एपिलेप्सी है जो एक दवा से ठीक हो सकता था, उसमें 4 दवाएं दी जा रही हैं. एक एपिलेप्सी है जो एपिलेप्सी ओरिजिनली है नहीं, वो मिमिक है, उसमें बहुत सारी दवाएं चल रही हैं. जो एपिलेप्सी है, जो एपिलेप्सी का इलाज होना चाहिए था, वो इलाज में चल के दूसरा इलाज चल रहा है. एक्चुअली एपिलेप्सी में एडल्ट एपिलेप्सी और पीडियाट्रिक एपिलेप्सी में ग्रॉस डिफरेंस है. ठीक है, क्योंकि एडल्ट का ब्रेन पूरा डेवलप हो चुका है, हमारे बच्चे का ब्रेन ग्रोइंग ब्रेन है. अगर एपिलेप्सी अगर 1 साल से कम में आती है तो उसको सीजर एक्टिविटी के लिए कम से कम दवाएं आपको चूज करनी है, जिससे उसका ब्रेन ग्रो कर सके, ब्रेन डेवलप कर सके, और वो अपना जो क्या कहते हैं गेन करना है, वो पूरा पावर के साथ अपना कैरियर गेन कर सके. थैंक यू वेरी मच. बहुत ही अच्छा रहा मेरा एक्सपीरियंस, और मुझे बड़ा अच्छा लगा यहाँ आया, और बहुत ही अच्छी तरह से इन लोग ऑर्गेनाइज कराया. वेरी वेरी थैंक यू मिस्टर राहुल, डॉक्टर राहुल, जो लंदन से आके इन्होंने यहाँ ये वर्कशॉप कराई. वेरी वेरी ग्रेटफुल टू यू. थैंक यू.
Thank you so much, sir. And now I would like to thank all the parents, all the doctors, all the therapists and everybody who has come here. और आप लोगों ने मिलकर अपने सपोर्ट से इस इवेंट को बहुत सक्सेसफुल बनाया है. थैंक यू सो मच. इस थैंक्स को बस हम ग्रेट करने के लिए हम एक्नॉलेज कराना चाहते हैं फ्रॉम आवर वन ऑफ आवर पेरेंट्स. सो आई वुड लाइक टू कॉल शिनॉयस मदर ऑन द स्टेज. सो मैम प्लीज कम ऑन द स्टेज. Please. Please, kindly give it to Dr. Neeraj with your hand, please. To just thank. Thank you so much, sir. And we are very great that we have new center is opening in Uttarakhand very soon. And we are going to announce that also. We are happy that Dr. Namrata is here. Shinoy ki mother. अभी आपको देना है. अच्छा तो प्लीज. ओके ओके. ओके, थैंक यू सो मच. I'm sorry, ma'am, you have to wait. Now, Gorakhpur से भी हमारे डॉक्टर आए हैं, डॉक्टर प्रमोद. So kindly please. Thank you so much, sir. Thank you. Thank you so much. Now we are going to wind up. If somebody wants to say, Dr. Rahul has to say something. Okay, so we are going to wind up. Thank you so much for your presence here.
राहुल को मिलना चाहिए था, ओके मुझे ठीक है. आई थिंक प्लीज कम ऑन स्टेज. डॉक्टर त्रोनेस प्लीज, बोथ ऑफ यू.
While you are waiting, please थोड़ा सा feedback दीजिए हमें और ग्रुप में बहुत अच्छा फोटो लगेगी. सर आ जाएं डॉक्टर सभी. आप कौन है? आइए, हम तो लंबे लोग हैं. आप खड़े हो गए तो पीछे. हम लोग बैठ जाते हैं. पीछे आइए. तो ग्रुप फोटो के लिए कोई रुक रहा है तो रुक जाए. ग्रुप फोटो.